Good morning, everyone. I'm Kevin Orford, Acting Chair of NHS Devon. Welcome to the September 2024 meeting of the Board of NHS Devon, Devon Integrated Care Board. This is a meeting held in public and which is streaming live to our YouTube channel. We've got apologies for the meeting from our Chief Financial Officer, Bill Shields, from the System Improvement Director, Alison Williams. We have apologies also from Mark Cook, the Managing Director, NHS England South West. We have apologies from Kate Shields, the NHS Cornwall Chief Executive Officer, and from Sheena Asthana, and from Philippa Harding, who is our Company Secretary and Interim Chief Communications and Corporate Affairs Officer. These apologies are related mainly to us having to move the board meeting to this new date, and I'm grateful to everybody who's been able to move their calendar commitments to be here, and I'm grateful also to Judy Hargaden, who can't be here in person because of the change of date, but who joins us remotely. And we welcome Lincoln Sargent, Director of Public Health at Torbay District Council, who takes up the role on the ICB Board of Partner Member for Public Health. Welcome, Lincoln. We also welcome Kirsty Denwood, who's the Deputy Chief Financial Officer. Kirsty is deputising for Bill Shields. We welcome again Alex Deegan, Director of Primary Care, who is attending to represent the Chief Medical Officer's Directorate prior to the commencement of Peter Collins in the CMO role. We continue to work with NHS England CMO to ensure that our interim arrangements fulfil all necessary requirements, and Peter Collins will take up post with us in October. We also welcome Richard Schofield, who's joining us remotely. Richard is from NHS England's South West region, and he's here on behalf of Mark Cook. And we welcome Hisham Khalil, a board observer, who also joins us remotely. Also, we welcome Sam Wadham-Sharp, the Director of Performance and Planning. And finally, we welcome Helen Braid, who is the Head of Governance and is here in Philippa Harding's absence on leave. We also welcome members of the public viewing the meeting online and those in the room here. I'd like to remind everybody that this is a meeting in public and not a public meeting. We've received no questions from the public relating to the items on the agenda today. I'd also like to let members of the public know that there will be a board meeting in private session to follow this meeting in public, and in the private session we'll be discussing items commercial in confidence relating to contracts, and we will be reviewing the latest draft of the medium-term financial plan. So before we start, Helen, can I confirm that the meeting is quorate?
Yes, we are, Chair.
Thank you very much. Then we can proceed. So moving down the agenda, we have the declarations of interest. These are listed as agenda item 1.2. Kirsty, I note that the board register doesn't include an entry for you. We spoke about this yesterday. Can I just confirm there are no declarations from you? Yep. Okay, we have confirmation of that. And can I just ask, is there anything which anyone else wants to add to the declarations, or anything which you need to draw to the attention of the board relating to the agenda today? Okay, in that case, we will note the declarations of interest. We move on to the minutes of the meeting, the minutes of the previous meeting. I'm not going to go through them page by page, but can I just ask if there are any points of accuracy which anyone would like to highlight, or any points which anybody would want to follow up? Penny.
Thank you, Chair. With regard to the action around right to choose, we are reporting this slightly earlier because it may reveal or inform further debate in the rest of the meeting. But Kirsty, you've picked up this action from Bill. Do you want to feedback?
Yes, so we've looked into the information that we've got on the right to choose, and we've identified all of the providers that are involved. The data we have is a mixture of adult and children, and it's not really easy to separate out, but what we're doing is going forward, we'll separately identify the children's activity from the adults. At the moment, it's all not separately identifiable and be a bit of a piece of work to do it retrospectively, but going forward, we'll be doing that, so then we can see what the increase in the activity is for that area.
And to note that it's the end of September that it's due, so we're working to that date.
Yeah.
Okay, thanks, thanks, Penny. Thanks, Kirsty. So, as I'm understanding that, we don't need a change to the minutes. This is just a follow-up and position statement as it stands at the moment. Okay, are there any other points of accuracy relating to the minutes which anyone would like to highlight? So if not, then the board approves the minutes of the meeting of the 25th of July 2024. Just to add to this, at the last meeting we had a question from a member of the public, Geraldine Arthurs, which related to the agenda item on the Teignmouth Health and Wellbeing Centre. And we undertook to respond to Geraldine in writing to that question and to make that response public. And the question that was asked and the response is included at the end of the minutes for information. Okay, we can now move on to the item 1.4, and we start the meeting today with a review of the last financial year 2023-24. And as an introduction to the annual report which follows, we have a short video which highlights some of the key themes of that previous year. So the video features members of staff who are talking about their area of work, and also Kevin Dixon, who is the chair of Health Watch for Devon, Torbay and Plymouth. And in the video, Kevin explains how NHS Devon has worked with Health Watch over the past year to better understand the needs of local people and communities. So if we could start the video, please. Thank you. 2023-24 marked our first full year as an integrated care board following our transition from NHS Devon Clinical Commissioning Group in July 2022.
As a new organisation, of course, we've had to adapt ourselves to our new and changing responsibilities and ensure that we have the ambition to deliver improved access and services and the best possible clinical outcomes for our local population.
Our challenges are not unique in England, but our starting position was one of the most difficult. And whilst we're making encouraging progress in some areas, there are others, such as access to urgent and emergency care, where we do need to significantly improve performance.
Of course, in all of this we have wonderful staff, and I would want to pay tribute to the extraordinary efforts that everybody goes to every day, whether that's in a frontline service or indeed in the support services that are so important behind the scenes, and also to our partners and stakeholders without whom we couldn't achieve what we achieved.
Addressing performance issues in urgent and emergency care remained a key priority over the past year, and we have undertaken a range of work to reduce pressures and improve patient care. This included allocating an additional 3.1 million of funding to support schemes, including providing extra capacity, establishing acute respiratory infection hubs, and working with GP practices to help reduce unnecessary hospital admissions. We also commissioned Health Watch to speak to people in Devon's 4 emergency departments to better understand the patient journey through the health system to the ED.
We were actually commissioned by NHS Devon to go into emergency departments across the county to actually ask people, while they were sitting there waiting to be treated, why they were actually there and how they actually got there, who referred them, did they come on under their own steam, or were there sort of better pathways that we could actually do? And some of that information was really useful. We fed that back to One Devon, and they instituted changes and different ways of sort of looking at that kind of situation.
So partners across Devon, Torbay and Plymouth are working together for children with disabilities who struggle to have their needs met in school, to make sure that we're improving care for them. And all 3 of our local authorities have got improvement plans following inspections from the CQC and Ofsted. So there are big programmes of work, and we are beginning to see some improvement in those areas now.
NHS Devon is responsible for commissioning a range of primary care services, including general practice, dentistry, pharmacy and optometry. Devon was rated the 2nd best in England for patient satisfaction with GP practices, with 8 in 10 people saying that they were satisfied in the GP patient survey. NHS Devon also took on responsibility for dentistry, pharmacy and optometry services in April 2023. We are deeply concerned about the problems that people are experiencing with access to dentistry in particular, and are working to address the long-standing problems that impact access. We have also worked with Health Watch to look at some of the challenges people face when accessing pharmacy services, such as repeat prescriptions.
It won't be surprising to find that one of the major things that we are picking up from communities and from patients is access to services. However, we believe that by closer sort of working with patients and working with providers, we can actually improve that kind of situation. For example, we did some interesting work on pharmacies, and we went out and engaged with communities to find out what patients were actually finding on the ground, and then we can feed back to our colleagues who can monitor and improve those kind of services.
The NHS in Devon has been working collaboratively to reduce the number of patients waiting for surgery, diagnostics and some other procedures. Our community diagnostic centres, where they are established, play a central role in this for the diagnostics, along with a host of other schemes. Where those centres are not up and running yet, we have installed mobile scanners in the very near vicinity so that people can access the diagnostic tests they need closer to home or without going to a hospital. For example, in spinal surgery, the number of people waiting for their operation was reduced by nearly 80% last year.
In July 2022, the Mental Health, Learning Disability and Neurodiversity Provider Collaborative was established. The aim of the collaborative is to deliver better health outcomes for people across Devon. During 2023 and 2024, the collaborative further developed its role within the wider strategic system and has developed strong working relationships with statutory, voluntary and community provider organisations.
On behalf of NHS Devon, I'd like to pay tribute to the extraordinary work of our incredible staff, stakeholders and partners across our One Devon system for the invaluable role that they play in supporting people's health and well-being and care.
There is still a long way to go as an organisation. We still have many ambitions that we're yet to meet. But I'm determined as we look forward into this year and beyond that we are able to meet those ambitions that everybody shares about making NHS Devon a safe and sustainable system for the population we serve.
Okay, and thanks to everyone who contributed to that video. What I suggest we do is move into the annual report and accounts and take any questions relating to the video as part of the discussion on the annual report. I just want to say that before we get into that, as we set out in the cover sheet to this item, the annual report and accounts were reviewed by the Audit and Risk Committee at its meeting of the 27th of June 2024, and the committee recommended that the board should approve them for submission to NHS England. And as a private meeting of the board on the 27th of June, we therefore approved the documents for submission, and today we present the annual report and accounts to the board meeting in public. Also included in these papers is the NHS England annual assessment of the Devon Integrated Care Board, and we'll consider that separately after we've discussed the annual report. So first I'd like to invite Steve Moore, our Chief Executive Officer, to take us into this agenda item on the annual report and accounts. Thank you, Steve.
Yeah, thank you, Chair. I don't actually plan to say very much for the reasons the Chair set out. We've had an opportunity to scrutinise this both through our committee structures and in our private board meeting last month, so the board will be familiar with the contents. Today is very much about receiving this in public and together with the video and the accounts set out our record of 23-24, both the challenges and the things that we achieved. I will just ask Kirsty whether there's anything that she wishes to raise on the annual accounts themselves, and then I just wanted to dwell a little bit on the third element of this, which is the annual assessment letter from NHS England. So I'll come back to that once Kirsty said what she needs to.
Thank you, Steve. Obviously the report I'll take as read anyway, but it's just worth highlighting that we met all of the financial duties that we were required to meet. So in terms of meeting our running costs, our cash payment, better payment practice code, and also the mental health investment standard. And the audit was an unqualified audit opinion as well for the accounts.
Thanks, Kirsty. So obviously happy to take any questions on any of that, but we've probably rehearsed many of those issues before, and I would just pay testament in all of that to the work that the teams do to pull these reports and accounts together. It is no small task to do that, and I'm very grateful for all their efforts. So the third part of this you'll see in the papers is the annual assessment letter from NHS England. I think it's a helpful external reflection on where the organisation has been in the previous financial year, and a real recognition, I think you'll see in that letter, about the fact that last year, for many reasons, was a challenging and turbulent period in our existence. it does, I think, really helpfully set out the successes and the progress that we've made, as well as those challenges that still need to be addressed. And actually, many of those challenges you will see as we go through the agenda are being addressed in those agenda items later today. I think probably what I would reflect on in relation to that is, even in the most difficult times, when you read some of the things that our staff and the wider system have achieved, it is really heartening to see that we can do remarkable things even when times are difficult. What is helpful to see when you reach the conclusions of the letter is that there is confirmation from NHS England that we've been working in compliance with our wider statutory duties and indeed contributing to the four purposes of the ICB. But I think I would leave the board with a clear sense, which I know we all share, that we're clear-eyed about where we need to improve and develop, and we need a medium-term plan to put NHS Devon and the wider system on a sustainable path, both financially and clinically. And that work is very much underway now. Happy to take any questions, Chair.
Thank you, Steve. We'll open it up for questions. Donna.
So a question for Kirsty. Sorry, Mr. Bell. We've seen in annual accounts that £78 million of savings and efficiencies were made. You know, what we don't see benchmarked is in terms of what other partnerships are having to achieve, but sounds like to me, although the challenge is significant and outlined by the chair, that we have a harder journey than many. That, you know, my question is, do you see that as positive progress to the year before in terms of what has been achieved? Because I think it's important for people to hear that. And also what I'm reading in that is a much more positive level of assurance in terms of our accounts. So I'm just interested in the kind of the journey of improvement and the benchmarking, because, wow, £78 million of efficiencies and savings seems significant to myself.
So the ICB and the system as a whole last year delivered savings a lot higher than any previous years, almost double than previous years. We still have the same level of target for 24-25, so the challenge is still with us for that period as part of our recovery programme. We're developing the medium-term financial plan, which we'll be picking up in the private session of the board, which will outline what the challenges we anticipate going forward are as well. I think in terms of the financial progress, I think it has been about system working in delivering those savings. So many of those have been done through collaborative working with our providers and not just in the ICB alone. And it is part of the recovery journey. We are having to deliver more savings than other systems purely because of the deficit position and our recovery plan that we and the progress we need to make. But we would hope that as we go through that journey, that level of savings will not go away, but it will diminish going forward if we can keep ourselves on track in delivering these.
Some follow-up, Chair. I suppose that I would ask, could there be some form of communication to partners and to staff in terms of just what Kirsty's explained, that more than ever before was delivered. We do have a difficult journey, but I think for people to hear that, because I think the challenge out there in terms of communication is that the ICB, you know, is not performing, it's not doing well, it's one of the worst in England. I think we need to put something out just in terms of what you said, because I think that is an astonishing achievement in difficult circumstances.
Thanks, Donna. And we can think about the best means of making that communication, but perhaps we take that out of the meeting and decide the best way to do that. But thanks for that, Donna. Is there anything else you wanted to say on that, Kirsty?
No, I think it probably is worth communicating. Yeah. It's about, we need to treat it as a success, don't we, and celebrate that in a way.
Yeah, thanks, Kirsty. And Liz?
Thank you. I just wanted to observe the way in which collaboration has become part of how we work as a ICB, that I think comes across in the report here, and also has been a significant part of the progress that's been made. I agree we've still got a very steep hill to climb. I just want to take the opportunity from a partner perspective to commend the staff within the ICB that have been material, I think, in supporting us as a system, as providers and as the ICB itself, to deliver on this. And we don't often take the time to thank the teams that have got often a really challenging job, she says, looking at a few people around the table, and a huge thank you to them.
Thanks, Liz. Steve.
Just brief response on that. I've got an all staff briefing after the board meeting, so I will personally feed that back. Thank you, Liz.
Thanks, Steve. Any other points on the... Oh, Graham.
Thank you very much. So the document it is clearly balanced and looking backwards. There are a few comments looking forward, which we should, of course, note. The conclusions does ask us to table at the board, which is now. It also asks us to publish it alongside our annual report and accounts, which I assume we will do. I do think we might just want to reflect a little bit and provide a response to the few points that there are in there, particularly around health wellbeing boards and the mixed response we get on that one.
Thanks, Graham. That's a good point. Steve, how would we want to respond to this? I think I would agree with Graham that it requires some response on a number of the points in there. How would we best do that?
We will provide a formal response back to NHS, and we wanted the opportunity of this board discussion first before we did so. So that will be in place. I do pick up the point, and there is already work going on to ensure that where we've had feedback from health and wellbeing boards, and as you say, it is mixed, that we're picking up those things and trying to improve going forward. So I'd hope the reflections next year will show that progress.
Thanks, Stephen. I just want Graham, just to come back to you. Would it be appropriate for that response to go into the audit committee and for that to be followed up a few months later, or would you prefer a different way of?
No, I'm more than happy to do that.
Okay. All right. So if we can agree an action there to get communication to stakeholders, and we'll determine the best way to do that. And Steve's agreed to raise with the staff meeting this afternoon the positive feedback that we've just received from our partner member Liz, and we're agreeing that we'll draft a response to the letter from Elizabeth O'Mahony, and that response will go into the audit committee, and the audit committee will follow that up a few months later to track the progress on that. So with those actions, I think we can note the final NHS Devon 23-24 annual report and accounts, and we can note the annual assessment for 23-24 of NHS Devon by NHS England. Thank you for everyone's work on that. We now move to the Chair's report. I'm going to take the report as read, but happy to answer any questions on it if there are any. So if there are no questions, we'll then note the Chair's report. We'll move on to the Chief Executive's report. So I'll ask Steve to present that report. Thanks, Steve.
Yes, thank you, Chair. And I just wanted to pick out a few elements, although I'm assuming people have had an opportunity to read it. You'll see an update on the organisational change. That we've reached an important milestone since the last meeting with the publishing of the structure following the consultation period over the summer, and a whole range of staff events that were held on the 11th of September. I would just like to thank my exec team, and indeed particularly the HR team who supported all of this in running those meetings. I think whilst of course there are areas of concern for staff, I think the clarity now that people have moving forward is going to enable us to make real progress now in finalising that structure and getting people into post. We had about 800 individual pieces of feedback. Firstly, I am really grateful to all our staff for feeling able to do that and for the insight that they gave us. That did allow us time to reflect on whether we got the structure entirely right, both for individuals and at a higher level. It's been very important, I think, to the team to ensure that we have fed back on all of that, either individually or where there are more systemic issues to the organisation more generally, so that people can see what was said to us and what we did about it, and in those areas where we weren't able to address the issue directly, why that was the case. And I think that's been a really helpful exercise for us. There's also in the paper, we continue to make progress on the phase 1 appointments. So congratulations to Chris down in Plymouth for his appointment, and we now therefore have all of our locality directors now in place, and they're playing an increasingly key role in the locality delivery group meetings that we have across the patch. The other things to raise are we do continue to hold regular incident management meetings in relation to collective action, and we were able to update through Anthony over the last 2 days with providers on the intelligence that's coming out in relation to that. I've now also personally met with all of the hospices. You'll know that's been an issue for the ICB for some time, and we have the task and finish group, which was established fairly soon after I started, progressing their work well. And I'm looking forward to a report back to board very soon now, and that we include the actions from that task and finish group, which has involved the hospices and indeed our palliative care providers in our 25-26 planning cycle. On children and young people recovery, you recall we had a discussion at the previous meeting. There's a progress update in my report. The resourcing for the waiting times reduction hasn't been entirely resolved yet. We have made good, solid progress in that regard, and we are in the process of finalising our trajectories so we can achieve what we set out to do as a first step towards the recovery and development of children and young people services across Devon. Also, my report to note the Ambulance Partnership Board establishment. I think a really helpful step forward for us. It does require an amendment to the ICB delegation, which I'm seeking approval for today. But I'm happy to take any questions on any of the report.
Are there any questions for Steve on the Chief Executive's report? Judy.
So I don't have a question. I just want to congratulate Steve and the team for progressing the work on children and young people so quickly. We very often get good plans coming to us, and it's a real joy to see at the next meeting that what we're getting is progress on funding these initiatives. Thank you very much.
Thanks, Judy. Graham.
Can I pick up on the Ambulance Partnership Board, please? So I think we all know here the important role that the ambulance service plays in the patient flow at various points. It's one organisation, but it covers multiple ICBs, which I know challenges its ability to interact with individual ICBs. So what is the issue that you're seeking to address by these changes? And will it actually address the fundamental problem, which is the dilemma they do have, is working with multiple ICBs? Why do you think it's going to provide a better way of working with them, please?
Gosh, that's a challenging question first thing in the morning. Thank you, Graham. I think the principle of working together on something, on a service which has a much wider footprint is a good principle. I think what the proposal around the changes here is to ensure that we've got a good governance process linked behind that, to ensure that both we have the local focus on the issues, and those issues were picked up in all of our locality delivery group meetings in the last few days, particularly around Cat 2 response times, but that we have a way in to do that collectively across the whole of the southwest. So I think it will come down to ensuring that our agendas are very clear, that what's happening at system level is the things that can only happen there, but we're taking the action locally. I think a good example of the work that's been started as a result of this way of working is the task and finish group that's been established, which is aimed at looking at the underlying reasons why Cat 2 response times perhaps are not falling as fast as we might think, we might expect, given the improvements in some of the ambulance weights across the system. And that's looking at a range of issues, some of which are cultural and workforce related. That's a system level, a regional level piece of work, and I think that's important because it needs to recognise that similar arrangements like this exist in other parts of the country, and indeed were very prevalent in Wales. They do work, provided the agenda, as I say, is clear, and what we do at regional level are only those things, and I think we just need to keep ourselves very clear about that.
Can I just follow on then? So this is a service commission via Dorset. How confident are you that the ambulance service has got the management bandwidth to engage with us in the ways that you're setting out to provide that locality piece to it? I thought they were rather stretched in the ability to do that.
Yeah, it is a challenge. I think it goes back to my point about ensuring that we do at local level only the things that can be done at local level, and doing those things regionally where we can. If we try and do both, we will stretch their bandwidth too far because they'll be having multiple conversations about the same thing. But it does remain a challenge for any service which is delivered on a very large footprint. We need to ensure we focus on absolutely the key issues that we need to on behalf of the populations that they're serving. So I think we need to keep that under review. I think we have probably an unofficial advantage in that the chief exec happens to be on our patch and is able therefore to be in some of our meetings perhaps more so than elsewhere. But we need to ensure that the partnership arrangement absolutely works, and that we're supporting Dorset in their leadership role in that.
Okay, thanks Graham, and thanks Steve. Any other questions on the Chief Executive's report? So if not, then we'll note the contents of the report. And is the board content to approve the amended Ambulance Partnership Board delegation agreement? Okay, thank you. We've approved that then. Moving on to item 3.1 on the agenda. This is the Recovery Support Programme assessment of NHS Devon, progress towards the delivery of exit criteria for NOF 4 in 22-23. First of all, we're going to take the Recovery Support Programme assessment of NHS Devon, which has been written by Alison Williams. Unfortunately, Alison can't be with us in the meeting today. So I'll just say the paper is in context of the fact that NHS Devon didn't meet the original timetable of moving from the 4th to 3rd segment of the framework at the end of June 2024, and that a new timescale has been set for the delivery of the exit criteria. In Alison's absence, I'm going to invite Steve to present her paper and also to do the initial response to it, and then I'll open the item up for questions from the board. Thanks, Steve.
Yeah, thank you, Chair. I'm very grateful to Alison for drafting this for us. Again, it is a backward-looking report, but one that I think is really important in terms of how we ensure that as we move forward, we are learning the lessons from the past. So it is a really helpful reflection, I think, on where we were last year and on some of the underlying causes for our failure to exit in the way that we expected. The reflections contained here have been used to strengthen our approach because, of course, we are now halfway into the new year. But I just wanted to pick them up individually because some of this will be picked up on other parts of the agenda. The first one was around planning. And I think what we've seen this year, and I came in relatively late to the planning cycle itself, but we've had a significant improvement in our planning this year, a much more robust system of working, which has allowed both a system-level plan and an individual organisational level plans with sufficient granularity within them to understand how we were going to deliver on the trajectories. Of course, they always balance ambition with realism, but the plan itself, I think, was therefore in a much better, sounder state this year, and I would hope that we will build on that approach next year. Been very clear through that whole planning process, and I know all my CEO colleagues absolutely agree with this, is that when we set out what we say we're going to do, we ensure that we do it. And the governance system that we set up, which was a second point for Alison, has been to ensure that we have absolute clarity about where we are against those plans, how that's feeding into delivery of trajectories, and where that is off track. And you'll note in the report later there are some areas where we are, whilst significantly improved, not yet meeting our trajectory, that we have the actions in place either at place level or indeed at system level to ensure that we get that back on track. So the significant piece of work we did this year to realign our governance architecture, I think, has been important. Relies on having a good plan to start with, though. So those 2 points very much go together. On the delivery point, we have, I think, for various reasons, a very strong, focused leadership effort around everything that we've put in place. We have developed and will continue to widen the use of the leadership compact. I think I can say to the board with strong reassurance that the sense of system working and desire to work together is strong. That's not without its challenges sometimes, and there are areas where we need to get into the detail of that, but the system and the individual providers within it have a much stronger sense of working together. We either all come out of NOF 4 or none of us do, and that's been very clear through the whole process. And also in terms of our delivery, ICB capacity and capability, we've strengthened some of that. I think, again, much more to do and when we think about our wider ICB recovery plan, but with the appointment of the Director of Transformation focused on firstly our 6 programmes for out-of-hospital care, and then more generally for a Home First strategy for next year, I think it's been an important step up for us, and we were able to feed back to all of the providers over the last 2 days where we are in terms of those 6 programmes, expected impact and timescales to get them fully implemented on the ground. And then finally, around board focus and development, again, I would just mention the session we had in a development session around my reflections and the recovery plan we need to put in place. And part of that recovery plan was to acknowledge that we absolutely need to stay in the here and now and ensure that we deliver on our commitments, both in the delivery of NOF4 exit and also our wider JFP commitments in our annual plan. And that we also, though, need to work on the wider piece to ensure that we have a strong ICB in order to support the wider system. I think kind of looking forward from this, we do absolutely need that comprehensive wider ICB strategy. The work that Liz has been leading around PASP is an important part of that, but we need to develop a strategy which wraps around the role in our ambitions around population health and prevention, care close to home and a strengthened primary and community model, and then a PASP programme which will deliver on an acute configuration which will be sustainable for the longer term. We've got much to do on that, and that was part, again, of my feedback to the board recently. And in terms of recommendation, I think we need to reflect on the learning. I think we have taken that learning into account, and we have acted on it, but there is certainly more to do in ensuring that we build on where we've got to currently and ensure that we never get back into escalation again. Happy to take any questions, Chair.
Thanks, Steve. And Alison asks us in a report to, as a board, to consider the learning from 23-24 and as a board for us to pull out any further actions that we think that NHS Devon needs to take in terms of strengthening the planning and delivery of the improvements required for NOF4 exit in 25-26. So I've got a number of hands raised. I'm going to start with Donna, please, and then I'll come to Lincoln and then Frank.
I'm interested in section 14 in terms of A to F, adverse variances. I suppose my question is there's one there, it doesn't give us an amount in terms of what the adverse variance is, E. So I wondered if we could have that figure. But in terms of, C, D and E, I'm just interested in terms of what learning will take place. Is it the fact that we need to realign the budget in those areas because it is likely to continue to be an adverse variance because it says it's unplanned? So are we setting the budget properly going ahead, or are we going to implement mitigating actions to address this issue? Because for all the good news and making savings in other areas, I'm always interested in adverse variances and then what we do to mitigate it. So and linked in with section 15, a pace is always a challenge in making changes. So we've got the engagement, but again, I'm interested in if pace is identified as being slow, what actions are we going to take in terms of personnel or governance to address the pace issue? Thank you.
I'll probably bring Kirsty in on the first issue, and Liz, are you happy to pick up the second one as it's in relation to the acute sustainability programme?
So the C to E, the main one is around prescribing, and the other one is to do with drugs. So this was a year where there was no alternative stock, cheaper stock available, and therefore this was pressure that was felt nationally, and it was recognised nationally. What we're seeing is we're not seeing that continuing this year, but we did rebase our budgets based on that overspending area, so that won't automatically be a problem for us going forward. We have rebased on that, but it was something that was nationally recognised in terms of shortage of certain drugs and having to pay a higher price. Majority of that overspend was price related, not volume. So we did check that our pharmacy teams were keeping on top of you know, were we prescribing properly, and what the levels of prescribing were. So it was a price issue. So that's where the main overspend is.
And I think on the specialling issue, we don't have that number yet. It's a piece of work we've asked the Mental Health Collaborative to pick up for us.
Thanks, Donna. And so I'll bring in... Oh, sorry, we've got to bring in Liz. Sorry.
If I may, I'm going to pick up one of the earlier comments that was made by Donna before I pick up the Pinwich Acute Sustainability Plan, because I think one of the bits that we absolutely need to recognise when we look at this report, and I have to say as a provider in this context, I absolutely recognise what's being set out here, some real progress in some really important areas and a lot more work to do, and we shouldn't underestimate the impact of being on NOF4 is across all of our sectors, I'm sure, including the ICB, in terms of maintaining the momentum, the energy, and ensuring, most importantly, you've got the right people with the right skills and capability, and the good governance and good information flows to enable people to give off their best. And I think when we think about learning going into next year, I would really commend that we continue to have the conversation about how do we support the leadership teams with things like the compact that you've described earlier, Steve, and making sure that we've got the right capacity and capability to deliver, because having a set of ambition and then not having the right people to deliver it becomes really, really challenging. In terms of the broader acute provider collaborative, it is a long-term programme. This is going to take 5 to 7 years to us to really deliver sustainable change in the longer term. The challenge for us is to do what was it we can do now in order to really improve the sustainability of services that are really impacting on access today. And the fragile services programme, I think, is something that we absolutely need to keep some focus on. We are recruiting additional capacity into the system. In fact, I'm interviewing on Friday for the managing director for this programme that I think can then start giving us some confidence that we've got the right capacity and capability to drive this programme that will move us on a journey to longer-term sustainability.
Thanks, Liz. The order, I may have got the order wrong of the people who want to speak, but I'm going to go, it's going to be Lincoln next, then Frank, then Tandy, and then Judy, and then Graham. And then Piers.
Thanks, Mark.
So Lincoln first, thank you.
Really good to hear you highlight issues like population health management, the clinical strategy in terms of some of the pillars that we need to embed to make this sustainable. I wondered to what extent we were including external partners in the planning and the delivery discussions. To what extent is this more central NHS versus locality? So the role of the LCPs, for example, where I think we have a mechanism to come together, because a lot of this, in particular in terms of the sustainability, will happen in localities. And particularly with the Darcy report around the pivoting from acute to community, how we take this learning, embed it, and for me that kind of, how do we balance central planning and delivery with the locality functions?
Yeah, thanks, Lincoln. There's probably two elements to that for me. So when we think about the development of a comprehensive strategy relating to population and public health, and probably more generally community resilience, I think the ICB's role in that is very much to convene the people around the system to be thinking about what that ought to look like. So I don't think, what I wouldn't be intending is that we would sit in a dark room and write a strategy. That is absolutely not our job. I think we need to be out there. So at strategy level, I want the benefit of everyone's wisdom and expertise in doing that. I think there is a piece for us to understand, and I think the Directors of Public Health can really help with this, around the nature of the strategic challenge we're facing and the role that population health can play in helping with that, because I think it fundamentally underpins all the other parts of the service if we get that right, and indeed if we get it wrong, how that pushes the system into difficulty. I think once we've got a really clear sense of poise around that, the primary community elements and indeed the acute elements of that, it would be my view that we would want to decentralise the delivery of that from the NHS Devon Centre team into our localities, and a significant strengthening of that relationship. And I can see that being, the LCPs being a really key element of that. I think we all need to agree, sort of at a Devon level, this is what we're trying to do. and then the centre needs to get out of the way to allow the localities actually to get on with delivering it, and that's very much part of the discussion I've had with the board.
Thanks, Steve. Thanks, Lincoln. Frank, please.
Thank you, Chair. There's a big thing in here about board ownership of this plan where we haven't delivered, and I'd just like to give a little anecdote because it leads into supporting Donna and Liz in what they've already said. The early part of my career, I was in the Navy. As part of that, I did 3.5 years with Royal Marines, and I did the Commando course. One of the exercises on the Commando course was 4 days on the moor, no sleep, or virtually no sleep, and very little food. And then they run you off the moor, and they have a wagon at the end of it, which you can see about a mile away. So you run about 12 miles across the moor, the wagon is a mile away, you get to within 100 yards of the wagon, and they move it off down the road for another mile. And the effect of that is to stress everybody on the course. And the reason I want to give that as an anecdote is the impact of the constant moving of the getting out of NOF 4 can be huge. And I really, really want us to commend the teams for what they have done this year, especially Bill Shields and the financial team and Sam Woodham-Sharp and his team, to deliver £212 million worth of savings. In any other system, that would be celebrated hugely. So in terms of the ownership, the failure for us to get out is the boards. The success of our staff has been phenomenal. And I think it's a really, really important point, and Donna and Liz have already spoken to it.
Thank you, Frank. So let's move on now to Tandy.
Yeah, so I just wanted to sort of comment on the point about needing to set an ICB strategy, which you've said, but it's also in that report. If you go to the BAF report, it does say there that there's no local risk that had been identified, and I'm just wondering whether the action there needs to be reflected in the BAF, as in what has come out of the system recovery programme recommendations need to go in the BAF for that reason.
Yeah, we'll pick that up. I think it's a good point. Thanks, Tandy.
Thank you.
Thanks, Tandy. And so we move to Judy, please.
Thank you very much. So the questions I usually ask about NOF 4 and the position we're in are about implementability. And Alison's report very much addresses that. I'm slightly confused that it is described as a backward-facing report, and yet it comes to us on the 2nd of September. So I am or Alison wrote it on the 2nd of September, and I would like to compliment her on a very clearly written paper. I'm sorry she's not here for me to say that to her. What it raises for me is this just granularity of why, who, and how we are not getting to the point where we can get on top of this. I hear in your presentation, Steve, that you are very confident that we're addressing a lot of the things. But could you or Anthony tell me now how, if I were to pick a line on one of the plans about a trajectory on UEC in one of our trusts, how do you, when you're sitting in a meeting, either the new locality assurance meetings or in your system overview group or in other discussions, how do you know that actually what is being said is being worked on? And this is not about me doubting people. I absolutely agree with Liz. Everybody's working extremely hard to do this. But it is a real concern that sometimes it's about capability, sometimes it's about capacity, sometimes it's about delegation to very junior members of staff. So I really want to understand how you know that a trajectory that you're putting into the plans, maybe it's Sam or Anthony that's in a better position to answer, is actually going to happen. What criteria do you use to know that?
That's a deeply philosophical question for a morning. There's probably the difference between reassurance and assurance and also improvement. I guess I would probably say four things, and then Anthony or Sam might want to reflect. I think the first thing for me, bearing in mind what I said about the fact that whilst we have put in place this year a much clearer plan, it's ambitious. We didn't sort of rest on our laurels, but the way in which those locality delivery group meetings have been established are very much based on being honest and clear with each other and having trust that this is about improvement. So where things are off track, how we react to that and how we support an individual provider or indeed internal teams within the ICB is a very important starting point, because unless we can be honest with each other in the room, you don't stand a chance of being able to get back on track with those things. The second thing I would say, and I think we've particularly seen this in relation to United Hospitals Plymouth position, is you want to see the evidence of impact. And actually what we've seen through their one plan is demonstrable improvement in the data. That for me is a strong indicator of, it's more than assurance, it's sort of proof really. Where we don't have that, and there are a number of areas, including still in Plymouth because they are slightly behind their trajectories in UEC as are the other providers, is then a discussion which reveals that we've got real clarity about what's causing us to be under or below trajectory, a real clear diagnosis of the problem, and a clear set of actions with calculated impact that are going to be taken, and then we use the locality delivery groups to drive and oversee that delivery. So it's partly backward looking, it's partly cultural in approach, and it's partly ensuring that there is confidence that there are plans in place and there's a clear understanding about how those plans are going to deliver. Hopefully that helps. Judy, I don't know if that entirely addresses your question. I don't know if Anthony might want to add to it.
Anthony.
Thank you very much. I think Steve's covered most of it within that. The one thing I would say is actually making sure you have a clear understanding of the diagnostic and actually what the actual problems are, and I think that's been perhaps the biggest and most significant change this year, is that common understanding. I think it's very easy to either externalise issues or to go after the wrong drivers of problems, and we took a lot of time earlier this year looking through what was lovingly called the Devon story, but actually was realistically a shared diagnostic, and I think that was a really important piece of work. So it does mean that when we come to the development and implementation of plans, we're working from the same understanding, and that makes the conversations so much easier, and also it makes it much easier for people to be honest with each other as well in terms of the elements that aren't delivering.
Thanks, Anthony. Before I bring Judy back in, I think the point that you've raised, Judy, plays to a really key theme in Alison's paper, actually, because I think Alison is the messaging that I'm getting from the report is that if we don't have detailed plans with clear actions, clear trajectories, it's really, really difficult for the board and for the board subcommittees to get assurance that the process is working well. So I think it's really important that we do note that theme from Alison's report and the way that you've asked the question, Judy. But do you want to come back on any of that, please?
I just wanted to ask the executives to make sure, because I think the board is absolutely behind the executives of our organisation and all the provider organisations and all the staff in getting this sorted. But it's really important that if things start to be problematic, and we've had ups and downs over the years, I really fully appreciate the answers that Steve and Anthony have given. It does feel so tangibly different to before. But we must make sure that the board knows if it's getting difficult. Otherwise, we can't know what we need to do to support the whole thing being implemented as quickly as possible, the whole NOF4 exit and all that. So I would ask that the executives make sure they keep us fully briefed on this.
So to respond to that, I'll just ask Steve to come in and then Liz afterwards.
Yeah, thanks, Joe. I think that's a really important point. We are at an important point in the year as well, being 6 months in, with some delivery behind us, as I say, some gaps to get back on top of. and the locality group meetings, which we've just finished yesterday, so we're just sort of digesting the output of those. I have said to each of the chief execs that I'll be writing to them, setting out what needs to be delivered in the next 6 months in order to be clear that we are going to be on course to exit North 4 in Q1 of 25-26. That will probably be really helpful to share with board members, and it might be that in discussion with Philippa, we may want to deeper dive that in one of our committees so that there's a clear understanding of what we're asking the system to do, including ourselves in that there will be some clear commitments from us.
And Liz, please.
Thank you, Chair, and I think my comment will follow on from what Steve said, because I do think there's something really important about having consistent and transparent reporting that goes to everybody's board, so that we are telling one narrative that also highlights the risks and issues that we need to manage both at individual organisations and collectively as a system. And I think the comment Judy makes, particularly around the transparency around when things are off track and the confidence that organisations have to flag things early and then take accountability for making sure that they're driven. And I think the current governance structure, from a provider perspective, absolutely lends itself to having some of those conversations because of the complexity of it, although there is absolute requirement to deliver on the actions that are owned within your organisation. The reality is delivery of this in a sustainable way requires consistent action on behalf of all of us, and having that visibility through consistent reporting, I think, can only help in achieving that and give confidence to have some of the difficult conversations, particularly when things are starting to go off track.
Thanks, Liz, and thanks for the question, Judy. That prompted a really useful discussion in the meeting. So, Graham, please.
Thank you. So, to be an effective board, we should not be surprised by the assessment part of this report, because it's our brief to know that. It is nevertheless very helpful and a very crisp and concise summary of that, so I welcome that. So it moves to me to then focus on the future considerations, and as you would probably expect me, I very much endorse the focus on the planning element as being a key part of it. There are two that I would just like to ask questions about, please. Paragraph 24, roles of sovereign boards versus system recovery board, etc. I think we're all aware that ICBs were given some leeway, different ones are doing different things for good purpose, etc. I suppose it's a question to you, Steve, sorry. Do you see this as something that you need to take forward? Is it you in partnership, or is it something that is also going to have some dialogue needed with Region and NHS England to get that clarity that is being suggested in number 24, the role of the ICB? So that's question one, which I know is a very difficult one, but nevertheless it's been raised. And question two is about the clinical strategy. That's a very broad thing. As you know, I've got strong views about what a strategy is and what it isn't, and isn't something that comes and goes in short order. So do we not need to unbundle a little bit more of what's behind the need for a robust clinical strategy in due course? So those two questions, please. Thank you.
Yeah, thank you, Graham. So I think on your first question, my initial response is I think we need to take ownership of that issue, and I think it's partly what Liz said. If we're going to have the right balance and the right arrangements around sovereign boards and the ICB and the wider system, it starts with having clear, consistent reporting to all boards. Everybody knows the truth, if you like, about where we are and what we're doing. I think it probably starts a step back from that, and I think we can build on that for this year. And we'll talk a bit about it in part two in relation to the medium-term financial plan development, is we also all boards need to feel that they are contributing to the plan fully, so that it isn't something that's inflicted from above. Then everybody is engaged and on board. I think that's going to be really important going forward. I think we've got some of the way there, but we've got more to do. It may be that there may be clarification coming regionally or nationally, but my instinct would be let's not wait for that. I think we can be, to a large degree, based on the leadership that we've got around the patch, in charge of our own destiny in these things, if we get it right. Liz, did you want to come in on that?
think the structures are really important, and I made reference to that in my earlier response. The thing that I would also reflect on is the nature of the relationships between the leaders across each of those organisations, because you can have all the structures in place, but it is the relationship that's been built. And I think the work that has been done over the last year, and certainly things like the compact that Steve's been talking about, lends itself to build a different set of relationships. And if I just speak specifically to the Peninsula Acute Sustainability Plan and the way that chairs, chief executives, medical directors, chief nurses are coming together to reflect on some of their future ambition and what that's going to mean for us collectively, I have to say gives me a bit of hope in this context, because you have to have both, don't you? You have to have that, the governance right, you need to be clear, you need to be consistent reporting, but you also need to have the relationships that back it up, and I do think that has improved immeasurably.
Good. And Glenn, remind me your specific question around the clinical strategy was?
Well, it's just a board term that I just feel there needs to be more work done underneath it, and what is the plans to get beneath that as to which bits of clinical strategy and an area of focus, etc. So I'm assuming there's some plans to take that forward.
Yeah, I mean, we had an opportunity in our development session just to talk about how we're going to approach that. So, and I absolutely agree. Strategies can come and go. What we need is something which is actionable, something which drives our agenda, and something which addresses the total need of the population and deals with the underlying root causes of some of the challenges that we face, which are ultimately population health and public health driven, but also partly driven by the way in which we're configured. So what I mean by a strategy is something that addresses all of those issues, is a comprehensive time laid out in time about what we're going to do when in order to address those things. And then there will be a set of in-year and probably multi-year plans which will be the stepping stones to get us from where we are now to that strategic future. So it isn't something that just sits on a shelf. As I said in the board development session, it needs to start, I think, with a board conversation and an exploration of the nature of the problem that we have, the nature of the challenges that we have, so that we can then go out to our partners and to the wider system and say, this is what we need, we think we need to resolve, and we need everybody on the pitch to help us resolve those things. All of the things that will then flow from that in terms of the workforce plan, the digital transformation plan, the money, performance will all flow from that point. But we need to get on top of that first. Hopefully that helps.
Thanks, Steve. Penny, was it on this point?
So briefly, so all that Steve has said, I think what's really clear is that we really build on the Peninsula work to understand our clinical and care model. We are part of an integrated care system, and I think that would be obviously part of our strategy to really co-produce that at the most senior level.
Thanks, Penny. So I have two other people waiting to speak. I have Piers, and then I have Hisham, and then we'll probably have to close the discussion on Alison's report. But to you first, Piers.
Yeah, thank you, Chair. So I won't repeat what other people have said, but I recognise everything that's been contained within the report. We've made good progress. We've got more to do. That's the general message, isn't it? And so we mustn't take our foot off the accelerator pedal. We also need to recognise that we've had some support through RSP. So my question really is, are we now clear what continuation of support we're going to get over the rest of this year and into next?
We're clear on the first point. We've had the confirmation letter in my inbox recently. We're not clear about going forward. Clearly, if our ambition is to get out of NOF4 Q1 of next year, there will be a change to the support arrangements. That's a discussion I'm planning to at least start to explore with NHS England when we meet them on the 17th of October.
Thanks, Steve. Thanks, Piers. And Hisham, please.
Thank you, Chair. My question relates from the ongoing discussion on whether there's a clear communication strategy from the ICB to the public and patients of Devon about the implications for remaining for the next few months in SOF4, and should there be, unfortunately, a persistence of that status beyond Q1 of next year?
Yeah, I mean, clearly through these meetings, through our communication out to the to the public generally. I would guess NOF4 doesn't mean a lot to people. What means a lot to people is the number of ambulances waiting outside, how long people are waiting for their planned care. Communications around those things, I think, are ongoing. Clearly, if we stay in NOF4, that will, for the public, will mean that we haven't been able to improve things sufficiently from their point of view, and that's really what drives all of this in the end. So I don't think we've got a formal communication plan around being in NOF4 or the implications of staying in it, but communications both from ourselves and from our providers around the challenges in the system and what we're trying to do about it are an ongoing thing.
Thanks, Steve. So Alison asked us to consider the learning from 23-24 and to take that into further actions. I think we've had a really good and thorough discussion on that, so thank you for everybody's contributions to that. Is the board happy to note the report from the Independent RSP System Improvement Director? If we are, then it is noted. And again, we've already said it, but thank you to Alison Williams for a really clear and comprehensive report. Thank you, Alison. So we now come up to the present position on NOF4 progress, the NHS Oversight Framework progress. So before we present this item, I just want to say the detailed performance data which supports this report was scrutinised in really close detail at the Finance and Performance Committee last week. And just to say that the committee did support the recommendations relating to the levels of assurance on each of the NOF4 domains. So having said that, I'll invite Anthony and Sam, I think. I don't know which one of you wants to start, but Anthony. Over to you first, please. Thank you.
We're very privileged to have the actual author of the report in the room, so I'm going to let him talk to it, because there's an awful lot of work that goes in that, and you've already mentioned the detailed data that sits behind it, but I'll let Sam talk us through.
Thanks, Sam.
Thank you. Good morning, everyone. So just to note, so this is a point-in-time assurance review of our progress against the requirements to exit NOF4. So this is based on the August review that was undertaken with each of our providers and our system leadership group, based on the month 3 and month 4 data that was available at that particular point in time against the 5 exit criteria. So against the 5 criteria of leadership, strategy, UEC, elective, and finance, we have recommended satisfactory assurance in 4 of the key areas, with the outlying area being in UEC, where we have recommended limited assurance at this present point in time. It should be noted that this is a different way of us reporting our levels of assurance, but we would note that we would recommend that means no significant change from the previous assurance that we were giving against those particular areas. As the chair has stated, there is an associated pack that sits alongside this paper with greater detail on the individual performance metrics, but also the detail around in-month delivery, the actions agreed, the risks and the mitigations which are gone through at each locality performance and delivery meeting, and also within our system leadership group and our regional review at SIAG. So to take each of the individual criteria in turn, so in terms of leadership for the month of August, so progress was made in line with the expected plans. The governance and assurance process that has been both launched and embedded in terms of our NOF4 exit across the system. The review of the ICS strategy has progressed to board stage in line with the agreed timeline, and our new NOF4 system architecture has been embedded in terms of those locality planning and delivery meetings and the SLG. We have recommended satisfactory rather than full assurance in this area because we believe time is required to understand whether that level of governance and those processes that we are embedding will facilitate the improvement and delivery required against each of those key areas. So we have recommended satisfactory assurance at that particular point in time. In terms of strategy, overall progress has been made in line with the timelines and the requirements, but it has been limited due to the lack of dedicated resource, as Liz alluded to earlier. We've noted that interviews were in place for both the managing director and the programme director in September that would mitigate. One of those posts has been appointed to, with the further interviews later in this week. Progress was made in line with the specific timelines in terms of phase 2 of the Peninsula Acute Sustainability Programme, with the draft case for change approved by the Provider Collaborative. There had been delays to public engagement due to the general election, and further conversations are ongoing around the next steps. So once again, we had suggested that that was satisfactory in terms of the level of assurance required for progress against that particular criteria. In terms of UEC, we should note the improved performance this year, but at the point in time, so this is the month 4 July data, we were not meeting trajectory for the criteria as required. So no provider, and therefore the system, did not meet the 4-hour trajectory in July. Plans and actions have been provided by University Hospitals Plymouth, which showed improvement through August and into September, and they were expected to meet their trajectory in August, which we can confirm now that data has arrived that they did meet trajectory in August. RDUH provided supplementary actions outside of the process with a commitment to return to trajectory within September. We have seen improvements in the data in September, but there is still a gap in terms of getting back to trajectory at the moment. A risk was raised by Torbay in terms of returning to trajectory, but a clear commitment to do so. And at this point in time, there was still further detail required on the actual individual impacts of the actions within Torbay, and that is still work that is ongoing at the moment. Whilst we have some assurance around the levels of improvement, getting back to trajectory, I think within that particular month in time across all sites was going to be difficult. In terms of time lost due to ambulance handover delays, we'd seen significant improvements again across the system based on improvements in both Torbay and University Hospital Plymouth. At the point in time in the July data, that had not influenced an improvement in the Category 2 handover performance, but we, as alluded to earlier within the ambulance work, we have started to understand what some of those other drivers might be rather than just ambulance handover delays. But once again, we have seen an improvement in the August data within that particular area. So at the point in time of this report, we've suggested limited assurance based on the fact that we did not meet our trajectories in July, and the further assurance required on the specific performance impacts of each of those individual interventions at each site, so limited assurance for UEC. In terms of elective care, so this is mainly around our long waiters, only RDUH met their 78 and 65-week trajectory in the month of June. Torbay met their 65-week trajectory, but not the 78-week trajectory, and UHP met neither at that particular point in time. The paper itself provides some of the specialty level detail and the mitigations in place that we won't go into here. All three providers at the point in time of this paper forecasted a return to trajectory, although with an element of risk within September. However, subsequent to this process, we have now noted that no provider is forecasting meeting their trajectory within the month of September. So what we would say here is that whilst at the point in time of this paper we were suggesting satisfactory levels of assurance, we believe in the next month's iteration we will move to limited assurance in terms of our elective care. Elements around NOF4 exit. In terms of finance, noting that there is a much wider finance report within the board today. At month 4, I think it's important to note that we were still forecasting delivery of plan. There was an emerging risk highlighted within the Torbay locality planning delivery meeting, but that is covered further within the finance paper, as are the mitigations that are being put in place to support. We were adverse 2.8 million of plan in month 4, but that is reflective of the impact of industrial action. And as of Q1, we were 0.2 million above our efficiency plan and still forecasting to meet the 213.3 million efficiency programme as stated within our planning round. There was a growth in risk. The growth in risk related to the finance plan rose in month 4 to 105 million, which was driven by risk to the efficiency plan, but our mitigations to the risks also increased in that particular month to 62 million, which left us a net risk of 43.5 million. So again, based on the fact that we were on plan within that particular month and the level of scrutiny going in around the efficiency plan, we have suggested an assurance level of satisfactory in terms of our financial plan at this particular point in time. So that is a run through of the paper. We would recommend a support of the Finance Performance Committee's review of those particular assurance levels.
Thanks, Sam, for that very thorough summary of the paper. Donna, please.
You know, I would argue they're very much an improving system, what we've heard so far today. And at this time of the year, there's what we see is variance in performance, but we know that things are changing, you know, at UHP. We also know that relationships are changing and strengthening in other places. So there's a lot of change, and that increase in capability and capacity is coming through. So I'm always interested when the comments about the winter plans and the expectation is to what extent, if we are not applying that learning and asking questions and asking for enhanced mitigation as we go through, you know, so I'm interested, what process are we doing there? Because I know in some of the engagement I'm involved in that we need to keep asking more questions in year as we go through based on learning previously, because the capability is greater. So there are some areas that we can build on. So it's that question about to what extent is the trajectory a backward look, or how present is it in terms of looking at that enhanced capability to actually achieve even more? Because I know the engagement that I'm having in the space responsible is that we're increasing our target as we go through, because we have more confidence in going forward. In particular, we tend to take fright about the winter plans, and then we get that, you know, so I'm just getting a sense, I suppose I like a sense of that, is that to what extent we are putting that, I don't say pressure on the system, because I think you balance it out with the balance of you're doing ambition. So to what extent we're bringing ambition in as the capability improves is my question mark, and the many changes that are taking place should be having a greater impact as we move through the year, I would suggest.
Thanks, Donna. I'll ask Sam to respond to that first of all, and then I'll bring Steve in.
I think the first thing to note is that the trajectories that we set at the beginning of the year were incredibly ambitious, particularly in comparison to both as Alison's paper would alluded to, the 23-24 performance position and what we'd looked at in planning previously, and we are starting to follow that through. If I take UHP as an example on their own, their 4-hour performance has improved 14% so far this year, based on the outturn last year. I don't think any other provider in the country can point to that. The other things that we are looking at it is very clearly there are interventions through the year baked into the trajectories, again particularly at UHP. So when their new urgent treatment centre comes online, we are expecting a further uplift in performance, not just sustaining that. And I think the locality planning delivery review meetings are allowing us to have a month-on-month review, knowing that performance can change hourly, but a month-on-month review around, based on the actions and the interventions being undertaken and the learning that is being undertaken at each of our individual sites. Firstly, what risk sits within the trajectory, but how further could we push things as well? So there is a commitment based, at least in 2 of the conversations that we've had this week, around pushing the trajectories further, either based on their own internal actions and understanding, or if there was additional funding for winter, for example, what could be done further. We were very keen to make sure that we included winter as part of our annual planning cycle this year, not on its own. We know winter happens every year, and therefore it should be included as part of our annual plan. There is a separate winter planning process, which I know is on the agenda today, looking at those specific mitigations for what we're expecting to see in terms of increases in demand. But winter is part of our annual plan every year now, and that is something that we're making really clear moving forward. So I think we are trying to stretch ourselves as far as we possibly can do.
Thanks, Sam. And I think on that same point, I've got Steve and then Liz.
Yeah, we've had a helpful set of discussions with the providers, and it is you do have to be balanced about these things, but very clear in the 3 meetings we've had with them this week. Improvement is really great, and we absolutely need to celebrate that. We have seen some remarkable improvement in all providers, actually, in many areas, but improvement won't get us out of NOF4. What will get us out of NOF4 is 2 months of 2 quarters of month-on-month improvement and getting to the trajectory. So whilst you're right, the sort of trajectory is a bit of a backward-looking. This is where we've got most of the discussions in those locality meetings are about what are the plans now to recover, what are they going to give you? And it's probably fair to say the providers are on a little bit of a spectrum about there are many things. There's an awful lot of moving parts, I know, in Liz's plan to get back on track, as there are in Plymouth. Being able to translate that into expected impact, and as Sam said, using the monthly cycle then to, did it work? Are we back on track? What have we learned? What are we going to do next? It's a much more dynamic performance improvement process than perhaps we've had previously. So you use the trajectories, but you look forward. And in all of these meetings, as we all agree across the CEO community, we have got to, in the end, hit the trajectories we set out. Whether or not we do that in the way we thought we were going to is sort of secondary for me. We just need to keep pushing ourselves to get back. That's what will get us out of NOF4.
Thanks, Steve. And Liz?
Thank you. So I think the challenge for us in terms of urgent emergency care kind of trajectories has to be about sustainability. So it can't be an in the moment. This needs to be something that you build and deliver on a credible, sustainable way. And I think one of the ways that we've been able to learn how to do that is learning from each other. And certainly from my, although I'm not here from a Torbay perspective, the opportunity to learn from some of the innovation in UHP, I think is really critical, and you know, big learning about clinical engagement and leadership. Big learning around my third point, which is it's a people stuff, it's a process stuff, but it's also an infrastructure issue. And I don't think we should forget that in order for us to deliver sustainable, consistent pathways of care, sometimes that infrastructure needs to be absolutely aligned. And as we're seeing some of that infrastructure investment coming in, we are seeing some of the benefits of that. And it was really interesting seeing the Darcy review and some of the kind of correlation that they're putting out around how do you ensure that your people are as productive as possible, and how does your capital programme align to that? And I think we need to continue to keep that in mind.
Thanks, Liz. So, Donna, do those responses answer your question? Thank you. So, we have next, I've got Alex, Tandy and Judy for questions. Then we'll probably, after that, we'll probably need to bring the item to a close. But Alex, first of all.
Yeah, thanks, Chair. I'm not sure whether it's a question. It's more of a comment, actually. But I think we just need to be mindful, and it's not unique to this system, is the impact of GP collective action over the rest of the year, particularly with regards to UEC performance, elective and finance. It really is a bit of an unknown quantity at the moment, but we're seeing kind of increased amount of collective action that will impact on all of those areas. I just wonder, but it's probably worthwhile us bringing something back to board maybe next month or the month after with regards to collective action.
Steve.
Yeah, just to clarify for the board, we have the weekly meetings, which is gathering evidence, and we are seeing some evidence now, as Anthony was able to report back to in our provider meetings this week, probably more in mental health at the moment, causing some concern and prescribing out in the community. I think it might be helpful to bring a position statement to the next meeting, because we would have had a number of the IMTs. As you know better than I, Alice, this is complex, and you don't know until you start to see some of the impacts. It's very difficult to spot up front, because every practice will potentially take different decisions, and even within a practice, GPs may take different decisions on those 10. So the process we have in place is to ensure that we are keeping the intelligence gathering going across the system and trying where possible to mitigate. Of course, as I think Anthony said in all of the meetings this week, the collective action areas have been designed to make them quite difficult to mitigate, but that is something that we need to keep under review. So happy to take an action for an update report on the incident management process we've got and the current state of intelligence at that point to the next board meeting.
Thanks, Steve. Tandy.
Yeah, so just commenting on the descriptors for assurance, I think this is a point that we picked up in the QPEC as well. In some ways, when we say satisfactory, sometimes it's feeling as if we mean getting back to trajectory. In some ways, it feels as if we are on trajectory. And I think it's getting a little bit confused and muddled, especially when we start talking about the RAG rating on the other hand, and then we start looking at the objectives. So I think we just need to really nail what we mean by satisfactory, limited assurance. I mean, is on target to hit trajectory, is that satisfactory or is that limited satisfactory? So I think we just need to really make sure that we're all on the same page and we mean the same thing by these descriptors.
Yeah, I think that's a really important point. Is there anything you want to say on that, Summer? We have been having these conversations outside of the meetings, haven't we? But I think Tandy's question is really pertinent to how we move forward on this.
Yeah, I think it's a work in progress, and I think that there's always going to be an element of subjectivity in some of these areas. But I think the clear thing for me is that it's either we are meeting the trajectory, or where we're not, we have a clear understanding of the reasons as to why not, and we can articulate what we're going to do about it and where the impact is. So it's assurance in our level of improvement and our assurance in our ability to get back to what we said we would, which I think that's the fundamental difference this year, is that we have a clear idea where we are off trajectory, the reasons as to why, and what we can do and will do about it. And then as part of this assurance report, it's following that through and being very clear. If we as an ICB or one of our providers said they were going to do something within that previous month, have we done it? Have we seen the impact that we would expect to? I think that's what's driving us towards that satisfactory element. But I think this is going to need further review, and I'm working quite closely with Philippa on it to make sure that we're getting the right level of assurance into the board.
Okay, and maybe we might also want to consider the timeline allocated, given the deadline to exit NOF4 in that. If that makes sense. So if we say we are limited assured, what does that mean to the exit date? Or what impact has that got to the exit date?
Yes, so obviously this sits as part of a monthly review process that we undertake with Region as well, and they have a slightly different scoring criteria in terms of the individual RAG rating. But I think, as Steve said, it is about the criteria as they're written, particularly around finance, UEC, and elective, are month-on-month achievement of trajectory over 2 consecutive quarters. So if you take that in the letter of the law as it's written, that is, we must achieve in October, and then we must sustain it for the rest of the year. To enable us to exit at that particular point in time. I think what we're trying to understand, what we're trying to articulate here is that if we're not going to meet our trajectory for a particular reason within that month in time, I think there's also that powerful element of understanding the reasons why, what we're going to do about it, and if we're not going to hit that original number, what's the new number look like, and then how do we get back to what we committed to previously? So I think there's the 2 elements that are running slightly concurrently, and we're just trying to manage that process as carefully as we can.
So I think Tandy does raise a really important point of whether or not we have a common understanding of what these assurance ratings mean. And so what we're hearing from you, Sam, is that these assurances are around the trajectory to date. I think what's really important then is that as we're doing the board subcommittee work, that we are looking forward as well, and we're having the conversation about the risks which are facing us in future months, as well as just looking at the assurance ratings for the trajectory to date. So thanks for raising that, Tandy. I think it's really important in terms of subcommittee focus. And finally, on this paper, to Judy, please.
Thank you. And actually, Kevin, you've just touched on what I was going to say. I would like to support Kevin in saying that we had a very detailed discussion about this with a lot of additional information at the Finance and Performance Committee. I think it might be very helpful if, in summarising or presenting a summarised paper for the board going forward, Sam, if we could add just a small section on the risks. For me, the risks are what's going to knock us off kilter. In the past, industrial action was one of those. We didn't know always when it was going to come, but we knew that if it did, it would knock us off. I'm very pleased to hear that that is now over for the junior doctors. We did ask one question, and I would be grateful if Sam could just summarise again so the whole board can hear. The work about what you're doing on predicting demand and changes in demand, because we've talked a lot about the plans and the trajectory, but if we get increased demand, it can undermine increased provision quite seriously. Sam, you answered that well in our subcommittee. Could you just clarify that for the rest of the board so we know they hear how you're on top of it?
Thank you. So I'll try to remember exactly what I said. So I think our planning process this year was a lot more detailed than it had been in previous years, and we were very clear on both articulating and calculating a level of demand that each of our providers could consume, particularly from a non-elective perspective, basing that on what we'd seen in previous years in terms of demand growth, demographic growth, etc. The elements of the out-of-hospital plan from the ICB perspective is aimed at capping that growth to the particular level of demand that each of our providers has suggested they could consume. that's as scientific as it can really get, because what we cannot do is understand what level of acuity we might see, etc. So there are bits within that. I think what we're also doing is a big piece of work at the moment to understand the levels of growth that we might be seeing within our system. And I think it's important to note that whilst we are seeing growth over the last 3 years, we are pretty much getting back to the levels of demand that we saw pre-COVID. In some of our particular, in some trusts, there is a discrepancy in the level of growth we're seeing in different areas. But once again, we need to do further work to really understand what does that mean in terms of level of acuity, types of presentations, etc., rather than just as a whole number. I think it's also important to note that particularly within some of our UEC performance, growth within type 3 activity is supporting a performance improvement at the moment, because we do perform very well in terms of our type 3 activities. That's our minor injury units and our urgent treatment centres. That is supporting a performance improvement, whilst we might still be seeing some tricky areas within our type 1 performance. But it is something that we're keeping under constant evaluation at the moment, particularly heading into winter and the demand profiles that we expect to see within winter. And it's also something that we're going to be closely monitoring within the GP collective action as well, to understand, is that driving demand either electively or non-electively in terms of referrals into secondary care. I'm hoping that's what I said last week, but it is a constant area that we are monitoring at the moment.
Thanks, Sam. That's really good. So thanks for all the contributions and a really good discussion that we've just had around that report. The recommendation is that we agree the overall assurance level relating to progress against the NOF4 exit criteria as satisfactory, and that we agree that adequate plans are in place to mitigate the risks relating to the delivery of NOF4 exit criteria identified in the locality planning and delivery meetings and in the system leadership group. Are we all happy to support that recommendation? And then I just want to echo what Frank said earlier, actually, which is just a thanks to all of the executive and their teams, and to you particularly, Sam, for all of the work that's being undertaken on the recovery programme. Thanks to all of you. Okay, we reached the point in the meeting where we can have a break. What I suggest we do, we're a bit over time, but I'd suggest we take 15 minutes and come back at 11:15 refresh. So thanks very much, and I'll see you all in 15 minutes. Okay, welcome back. And after the break, and we now move into the section on governance, performance and assurance reports. Item 4.1 on the agenda is the quality report. So over to you, Penny, please.
Thank you, Chair. And to note to board members my appreciation that quality is at the top of this part of the agenda. So the report I will consider has been read. I'll take you through the executive summary, but overall assurance is satisfactory, noting that there are areas of concerns that are being escalated for information, but there are additional focus on mitigation actions in place. So the quality report should also be considered in conjunction with the chair of PEC's report, and so I will avoid areas of duplication, Tandy. So a particular note is the work on safety. So this is within the annex of the operating plan 24-25. There are 2 or 3 really key areas of focus, one of which is implementation of the patient incident and response framework. So all now of our providers have now transitioned, and we are also doing work within primary care. So you will note that this quality report doesn't attend to primary care quality. There is a deep dive at our future QPEC, and no doubt our IENs will be interested in that, especially Judy, who chairs the group. So in terms of developing and improving assurance, Never Events is another area where we have a really key focus. What's really assuring, actually, is the work within TSD, that you're taking the learning approach from RDUH around Never Events, and I am assured about the rigour that is being taken within the providers around that, but obviously we remain interested in the learning. This report really needs to focus on our statutory frameworks as well. It doesn't duplicate the information in the annual plan, so you will notice there is an objective in the annual plan around driving improvement in safeguarding. We need to make sure that the learning from things like our serious incident reports, rapid reviews, SCRs and so forth really feed into that quality improvement mindset. I'm really pleased to see Lincoln here. We've been corresponding regarding matters around TB, for example. John Trevane has been leading recovery work, I would say, in infection management. We were very strong in terms of things like COVID vaccination, so that's excellent. But there are some issues arising around how we have governed infection management, and that's being addressed promptly and with good effect. The other area that I would draw your attention to is maternity. So maternity is subject, all 3 of our providers are subject to the National Maternity Improvement Plan, and that's because those trusts were rated requires improvement by CQC, but also because those providers are in NOF4. And so there are some themes arising, although diagnostic work is still being undertaken by the National Maternity Improvement Advisors in collaboration with Trust. So we will be holding in November a joint strategic meeting to understand what are the themes and how do those link to the maternity PASP work. We need to do breadth and depth there. In terms of mortality, it's fundamental that me in this role and the incoming CMO work together around mortality. And what's really positive, Steve, is that your push actually to have quality is a really key focus on the locality meetings. Necessarily so, we've focused on things like the quality impact assessment this month, because again, that's stated in the operating plan, so we're having a deep dive around that. But really pressing into issues such as mortality, clinical effectiveness, and crucially patient experience. And I didn't rehearse this with Frank in advance of the meeting, but you mentioned sleep and sleep deprivation. So when we come to talk around things like patient experience, very often we look at friends and families tests and so forth. But I really want to get into the space of So how can we improve that patient experience? And one of the key things that that people cite is not being able to sleep well. So I want to make sense of all of these data into tangible improvements for patients. I think the other area that we really must continue to focus on is our children and young people. So it's helpful in some ways to see the wider focus. So in this report, the quality team have been looking at reducing surgical waits. One of the areas I think of great collaboration now is myself and Anthony Sam Waddington-Sharp around the children, young people agenda. And again, when we look at the wider community waiting list, there is forthcoming, and I think Sam's still in the room. Yeah, there is forthcoming a mental health data set. And can I just ask you to comment on that for me, Sam?
Sure. So one of the issues I think we've had previously is our ability to display the total understanding of the waiting list size, waiting time, issues within mental health and particularly within children and young persons. So within the last 24 hours, a new regional request for a data set has just landed with us that we'll be working with our providers, which I think will give us a much better understanding of the total waiting list size, shape, timelines, etc. So we will be working to implement that and to bring that into our annual plan reporting as quickly as possible. Alongside that is a request for a point-in-time understanding of the total number of 104-week waiters in mental health. So we're being asked to provide that on the 8th of November back to region. My perspective would be that we should be using that as part of our monthly reporting anyway, in line with any form of referral to treatment time. So we should have a clear understanding at not just 104 weeks, but 52 weeks, 18 weeks, etc. It's not an 18-week pathway. We should know that, but we will have a very clear understanding, I think, within the next couple of weeks of our providers' ability to be able to provide the data against that data set, and also our ability to provide the assurance to the board on what that means and the improvements attached to it.
Thank you, Sam. So, as I say, I don't want to duplicate those escalations coming up from the Chair's report. The final statement I would make is the NHS England have developed a national quality framework, and we've done a piece of due diligence. So going forward, the quality report will give assurance against our delivery of that quality framework, because there's a really clear distinction between what is an ICB accountability and what is a provider accountability. We have oversight responsibilities, so that will still feature the report, but it's really important that you capture as board the quality performance of the ICB. That's it.
Thanks, Penny. That's really helpful. So let's open it up to questions. I have Donna first. Thanks, Donna.
A few questions. First one is in terms of noting the maternity section that mandatory safeguarding training is stipulated here. So my question is, have we got assurance that we can actually monitor the uptake of mandatory training? Because very few organisations report 100% uptake of mandatory training. So it's something we need to work on. So that's the first thing, is I do think we need line of sight and our performance metrics on the uptake of training across the whole system, especially with safeguarding. That's one question. The second one is, I'm aware that in terms of supply of medication for young people at the moment, there's been a lot of concerns about supply levels linked to particular areas, and I just wonder if that kind of availability of medication for young people and the risks around about that will be brought in to be monitored. And I suppose the third thing is really just in terms of we're seeing that risk through water pollution is increasing in incidence, and particularly around the southwest we've had some significant incidents. So I'm just wondering, in terms of that risk assessment to people, whether infection through water consumption or so on will be built in. Yeah. Okay.
Helpful, Donna, and suitably specific. So we are working with our business intelligence unit to develop our children and young people data set. Part of that will be capturing both internal health mandatory training, which we do through ESR, but fundamentally the multi-agency training, and making sure that we've got the training needs analysis properly developed by provider. Yes, it's not there yet, it's part of the design. In terms of supply of medication, particularly this is, our children who are neurodivergent, they can be particularly at risk, and actually we've heard some really difficult stories about children having to face them exams, for example, without the right supply of medication. What I'd like to do is invite Alex, if you have any insight in that space. If not, we will need to go away.
Thank you, Penny. I don't have any particular insight other than perception as a practicing GP that it seems to be a bit less of an issue, but I think we should probably take it outside the room just to double check. I don't know whether Frank, is it something you're aware of?
Yes, I don't think it is any less of an issue. Supply of medications is a huge problem. Most of the children on ADHD medication, it should be under secondary care advice. The formulation of the various drugs are different, the timing is different. So GPs should not be making the decisions about change, and what we get is a supply problem. So it is quite complex and ever increasing. It actually leads on to something else I was going to say, actually, so I don't know if you want me to... I am delighted that Region are asking about 104-week waits in children and mental health, because it needs to get onto parity with physical health, and I think that's great. The figures in here, don't be fooled by the Plymouth base, because that's only one little part of Devon. The total figures are much bigger. But the main thing I wanted to flag up was the right to choose. The right to choose is not just about choosing where you go, because it puts you on a completely different pathway that flips in and out of the private sector. And we are going to use it as a means of us reducing waiting lists. If people are put on ADHD medication, for instance, by a private provider, at the moment there are issues about whether GPs will then are supposed to pick that up and do shared care. So we need to think through the whole pathway of right to choose. It's not just about the point of choosing your provider. And there are cases, I've had one, where a child was sent to a provider in December. The provider's contract was changed with the NHS in March. We were told in August that child needed to be directed somewhere else. And no one, as far as I'm aware, had communicated with that child. So right to choose is a real issue across the whole system that we will need to pay particular attention to.
Thanks, Roger, to pick up that issue of the whole pathway on right to choose.
I think it's an issue that we need to take outside. It's so complex, but I think we're all cited on I had prior conversation with Donna actually about implications around a lot of this. So probably not for further discussion in this space, but it's something that we should bring back to probably a committee of the board in the first instance. Yeah.
Okay, let's have that as an action then, to bring that issue to a board committee, Quality and Patient Experience Committee. Okay, let's agree to do that. Thank you.
And then the issue around water quality. So we are working increasingly closer with our directors of public health and public health consultant. This is, again, an area John Trevains and Anthony Shannon has been working on. So we dealt with, obviously, didn't we? We dealt with in Torbay a very significant repercussion of the water quality, and it really rocks public confidence. Lincoln, can I ask you if you've got a view that you'd like to bring forward as well from a broader perspective?
This was related to the outbreak in Brixton?
Yeah.
Yes. So we had a breach in the integrity of the water supply in Brixham that affected about 17,000 households in that catchment area. Thankfully, in terms of hospitalizations, we only had three people, 4 hospitalized, 4 episodes, I think. And estimates are we had a bit over 100 confirmed cases with lab confirmation, and probably about 500 people who were symptomatic around that episode. The upside, I suppose, is that catchment area is now probably one of the safest in terms of the remediations that have been done. But Penny is right. It's one of those never events in public health as far as I'm concerned. And the Drinking Water Inspectorate is leading investigations. We would expect them to take some action in terms of holding South West Water to account for that. And there's a lot of learning that we've done in terms of picking up those issues earlier. So you can't guarantee that there won't be a break in the water catchment system, but certainly being able to pick that up more quickly, being able to speak with key partners so that we could have been on top of it. And it was unfortunate. My first indication was through social media and through Brixham Town Council, not through the official stuff. And in fact, they were giving us strong assurances that all was well until, it came through that we had a contaminated water supply.
Yeah, so it's a real example of truly collaborative working, and which is why the work that John's been doing with Directors of Public Health to really strengthen those partnership arrangements. And one of the issues, of course, we're working on at the moment, Lincoln, isn't it, is about really establishing accountability for health response to outbreaks. So it was very helpful, obviously Lisa's got first-hand experience of responding to that and also receiving the consequence of it in terms of being your staff being part of the population. But it's the infection, I won't go on too long, but the infection management profile is changing rapidly. So alert organisms previously were relatively stable. We are now seeing really quite different presentation in things, in terms of things like incidence of TB and so forth. And that's for various reasons. It's infection control needs to have very increased prominence in the ICB, and we're working to that end.
Thanks, Penny. Are there any other questions relating to the quality report? If not, then we'll note the action that we will take into Quality and Patient Experience Committee, some work around the whole pathway relating to right to choose, which was the point which Frank raised with us. And is the board then happy with the recommendation that we note the overall assurance level relating to the quality position of the ICS as satisfactory, and that we support our position that adequate plans are in place to mitigate and improve quality risks? Are we happy with that recommendation? Okay, thank you very much, and thank you, Penny. Let's now move on to the 2 finance reports, and before I invite Kirsty to take us through these, just for the board's information, these 2 reports were scrutinised at the Finance and Performance Committee last week with all its supporting data, and the committee supported the recommendations relating to the levels of assurance for each section in the report. So with that introduction, I'll invite Kirsty to take us into the reports. Thank you.
Thanks, Chair. So the ICB finance report to start with. So this has got overall satisfactory assurance. It's had an improvement in one of the assurance ratings on the risk section, where we've now mitigated a larger element of the risk. The unmitigated risk is now down to about 2.9 million. So the overall we're on plan. So the forecast is on plan and the year-to-date position is on plan. The area where there is risk and there's limited assurances around the savings and efficiencies, particularly in one of the areas where we were hoping to take underspends from dental even after we've done the dental recovery plan into the position non-recurrently. There's an indication that any unspent dental funding will be clawed back. We are doing everything we can to spend it anyway, but it's quite difficult when there's not the dentistry network there to do that. So we've left that one as a high risk on delivery because of the clawback. But all of the other saving schemes, we've now got plans on a page and are working with all of the execs on the delivery of those and the trajectory. Most of the savings, the bigger ones, do come in the second half of the year, but we are gearing up for that, and the expectation is that they will deliver as planned.
Okay, thanks, Kirsty. Any questions on the ICB finance report? So if not, then can we agree the overall assurance level relating to the financial position of NHS Devon of satisfactory assurance, and agree that adequate plans are in place to mitigate the risks relating to the delivery of planned savings and efficiencies and to the management of financial risks identified at plan stage? Are we happy to agree that recommendation? Okay, thank you. And on to the ICS finance report for Kirsty.
Yep. So the rating on this again overall is satisfactory, which is no change from month 3. The limited areas are the savings and efficiencies and the financial risks. So overall, we have a planned deficit of 80 million. In terms of the SIP, we've got no unidentified SIP now across the system, and we've got a target to reduce the high risk level of SIP to less than 20% by month 5. We're on 23% as at month 4, which is an improvement on month 3. So we're hoping we will achieve that, which is a requirement from NHS England as well. Again, the SIP target is high, like last year. It's at 213 million, so it is a challenging position. The only place that we're off trajectory is the year-to-date is all in relation to industrial action. However, we have been given indication, although not confirmed in writing yet, that we will get funding or an element of funding towards the industrial action costs. So that's again a mitigation that's helping the risk position that will get funded. We've done reviews with all of the organisations to see if their efficiency plans are on track, because there is a bit of a hockey stick in that they do ramp up throughout the year. The first test of that was there was a bit of a ramp up in month 4, and all organisations achieved that. So again, that's why we're saying we're satisfactory overall at this point in the year and based on the information that we have around forecasting. The one area we do need to be mindful of and keep an eye on is the recurrent versus non-recurrent element of the efficiencies. So we're slightly behind plan on that. We've discussed that in the locality meetings this week, and we've got indications from the 2 providers which are behind that those positions should improve going forward, and hope to come back on track for those. That's really important because it protects our underlying position going forward into our medium-term financial planning. The risk level is down to about 44 million overall. That sounds quite significant, but I think if you compare that to this time last year, that's lower. And being in NOF4 and the level of savings that we have to deliver, there is always going to be an element of financial risk which we feel unable to mitigate at this point in the year, but it is coming down each month. So as at month 4, that's a reasonable risk position, but we have said that is still limited because it's not all fully mitigated. Just to pick up on workforce, so overall the workforce as a system, we're on plan. There are pockets between the different providers where it's slightly different, but the agency is 2.1% forecast against a ceiling set by the national team of 2.9%. So we are one of the best in the southwest for our low agency usage, albeit it is a challenge for us because further reductions are required as part of the efficiency programme. So it's not something that we can take our foot off the gas for, basically. So that's in a nutshell where we are with the system.
Thanks, Kirsty. Are there any questions for Kirsty on the ICS financial position? Graham.
Actually, it's not a question, it's just a reflection, because not everybody here was party to that meeting. There is more detail. We did scrutinise that quite a lot. And I've been known to obviously ask about how backloaded for the SIP plan, and we now can see that. And as Kirsty's already said, it is indeed backloaded. But right now, there is no reason, given that we are on plan, to change our assessment. So I think it's fair to say we concluded the assessments based upon the information we've got in front of us recognising there's still quite a challenge ahead. So,
thanks, Graham. Okay, if there are no further questions on that, can we agree, or we're asked to agree, the overall assurance level relating to the financial position of the One Devon Integrated Care System as satisfactory assurance, and to agree that adequate plans are in place to mitigate the risks relating to the delivery of planned savings and efficiencies and to the management of the financial risks identified at plan stage? Are we happy to support that recommendation? Okay, thank you. We move on now to the performance report, and again, before I invite Anthony to speak, I just want to report that the Finance and Performance Committee also received this performance report at its meetings last week, and in those discussions at committee, we focused quite a lot on the report conclusions of limited assurance relating to services for young people and also to community waiting times. So Anthony, in introducing the report, perhaps you might just like to highlight those two areas of limited assurance and to give some assurance to the board on our position on those.
Certainly. Thank you very much, Chair. For those people who are observant, you'll notice the report has gone through some changes, and that's to simplify the reporting process, but also to take away the duplication in terms of reporting, which sometimes has led to some confusion. I think that being said, there are a couple of things I do need to highlight, and obviously in terms of this report, what we'll be looking for is further opportunities as to how we can merge this with our annual plan reporting process as well going forward. That being said, in terms of the main body of the report, I'll ask you to note the elements in relation to elective care, but in terms of community and children and young people, we have been undergoing a process with our providers unpicking what sits within community waiting lists. It's an interesting area with at least 28 individual domains, all with very difficult definitions. And that means looking at parity across providers is somewhat difficult. We do know, though, that we have seen an increase in our waiting lists, and particularly in our children and young people element, but also within our MSK services. Some of those relate to counting and coding. Some of them require further validation. And a piece of work that's going to be going over the next 6 weeks is to validate each of those elements to come back with the true position of where we are. But suffice to say, there is a lot of work to do within this. There is also a number of long waiters as well. So community rehab services in one area particularly has some very long waits. But as we've already mentioned, certainly the children and young people is the area that is causing concern for us at the moment. So to take some reassurance that the work is ongoing, but actually in terms of assurance for the report, we're not quite there yet. I'd also like to draw people's attention to the mental health section, and we have spoken already about actually the work that's ongoing with the collaborative to look at not necessarily the areas that are contained within this report, but the other pressures that exist within mental health services, and certainly those that are going to impact on us across winter. That work is currently ongoing at the moment. In terms of the other elements in the report, I'll take that as read, but in terms of the overall body, I'm happy to take any questions.
Thanks, Anthony. Are there any questions for Anthony on the performance report? Steve.
Sorry, it wasn't a question, it was just to pick up the discussion that we've had at the locality delivery group meetings, that whilst they have been focused on the NOF4 exit criteria, we have agreed for the next meeting we're going to be taking community weights through that discussion, so we start to bring that into the wider consideration about performance improvement.
Frank.
Thanks, Chair. There's just one detail about primary care workforce. I've been asking for 2 years what that data would show, and I found out recently why it's not got to the board. There is a thing called the National Workforce Reporting System, and all practices and PCNs report into it. And I went to a PCN workforce meeting recently, and each of them was presented with their own data and asked how accurate it was. So this is data that they have fed into the system, or somebody lower down in their organisation has, and they all looked at it and said, oh, it's not accurate. So we're slightly blinded on the situation in primary care. The most important statistic, though, was 30% of the workforce in primary care are over the age of 55, and we need to be aware that there's going to be quite a challenge replacing all of them.
Thanks, Frank. Does anyone want to come back on that issue? Pierce?
Happy to comment on it. I think Frank's absolutely right. We know that's another significant challenge for us in the workforce, people community. It's not been as significant a focus for us over the last year, probably, because of the pressures on operational plan delivery, but it absolutely needs to be. So I absolutely recognise what you said. The quality of the data is something that's been a problem for many years, and we need to continue working on that as well. But the information it gives us at a high level tells us enough that there is things we need to do. I absolutely agree. So just some reassurance that we recognise the need to continue investing in and supporting that particular part of our workforce.
Thanks, Pierce. And I'll just invite Steve to add to that.
Yeah, it was just to link it back to the discussion we had earlier around the development of strategy, and that's starting with an understanding, a shared understanding of what the nature of the strategic challenge is. Absolutely part of that needs to be the workforce demographic challenge, because whilst we have a population demographic challenge, actually much of our senior workforce, the 45 to 64-year-olds, that's a falling population for us, and that's going to be in primary care, in acute, it's going to be everywhere. In understanding that, we then need to get people around the table about actually what are the options to help solve that, and that's going to be challenging for all of us. But once we've got our head around it, at least we can start thinking about potential mitigations.
Thanks, Steve. And Lincoln, did you want to come in?
Yes, and I'm sure you probably have discussed this at length before, but I just wanted to highlight speech and language and that critical period 2 to 4, because what we are finding, particularly in terms of SEND and others, the knock-on to young people, and we know the challenge with COVID and all the rest of it, but there are certain periods where waiting times have a criticality above and beyond, and this is one of those that if we don't intervene quickly, we then get children who might have changed trajectory going on to have lots and lots of challenges going through.
Yeah, thanks for that point, Lincoln. We have discussed that at the board previously, and we are committed in the planning round for 25-26 to really understand how we can respond to that to turn those trajectories around. But Frank, is there something you wanted to add to that?
Yes, specifically on the SALT data. My experience as a clinician is quite a few children who might actually have ADHD or autism get somehow put into that pathway to try and explain why they have a problem. And so I think we need to look at both of those sets of data together and understand whether some are being put into that pathway I think sometimes there are good clinical reasons, but other times it feels like they're not on the right pathway.
Thank you, Frank. And Liz?
I think we've had a number of conversations around this table around the importance of that children's agenda, and I think from a provider perspective we really welcome the focus and the opportunity to come together. The notes make reference to the engagement with Torbay in particular as the lead for CFHD, so that we can start thinking collectively around where the priority focuses need to be and how we're going to collectively look at the capacity and capability that needs to be put into those pathways to address those very issues, because we absolutely recognise them.
Thanks, Liz. And I think what I'd like to do is just kind of take an action, which I think we're already committed to, that as part of the planning round for 25-26, that we do some early detailed work on the issues that we need to take into the planning round for next year. So let's take that as an action from this. Donna.
Can I just ask though that this matter has been raised as in terms of many of local government networks. The SEND system is seen as the biggest priority across all local government networks, across all political parties, as a challenge to be discussed. So I think we've just got to keep line of sight on what's happening nationally as well, because this is, we're extremely challenged in our area, but it is a challenge for everyone. And I think that work has to be engaging with national government as to some solutions for us that might be quite different from other areas, and we need to make sure that all the opportunities and working groups and representation that we're very much represented, because I do think that although it's challenged nationally, we have different challenges here, and that has to be recognised. So I think we just need to agree that we're going to have line of sight, and this is a national development.
Thanks for that, Donna. Okay, if there are no further questions on the performance report, the board is asked to agree the individual assurance levels relating to the performance criteria contained in the report, and to identify any areas that require further assurance. So I think we've identified those in the conversations that we've had. Are we happy to accept the recommendation? Okay, thank you very much. We move on to item 4.4, which is the delivery of the 24-25 annual plan. This is a new paper on the plan delivery, a new assurance report which sets out assurance levels on the annual plan progress. I'll invite Steve to present the report.
Yeah, thank you, Chair. So as the board will recall, keen to ensure that we are addressing all of our priorities set out both within the operating plan, which is an expression of the challenges in NOF4, but also more widely in our joint forward plan. So this sets out our objectives that we've set ourselves for this year in relation to the joint forward plan commitments that we've made to ensure that we do have that comprehensive view of delivery. In terms of process, the delivery is overseen both in my one-to-one meetings with my exec directors about how they're doing in their individual areas, any challenges, and ensuring that we stay on track with those, and also through our refreshed senior leadership forum meetings where we have the wider team in and we discuss progress, blockages and what we can do to recover. And all of that supported very ably by Sam and the Programme Management Office between those meetings to ensure that there is driving the delivery of the clarity of the plans and in-year delivery of them. I'm keen to ensure that in all of this is about there being much more clarity around accountability and discipline within the organisation, again, to set out what we're going to do and then ensure we have the plans and process in place to do it. I would, though, acknowledge that this is a bit of a point in time, and I would expect to see further improvements in this as we go through the 25-6 planning cycle to ensure that our objectives are absolutely clear. What are we going to do by when? That they will have direct executive ownership, single executive ownership, even if it crosses portfolios, to ensure we know who we need to look at in the meetings, and that all of the individual objectives are assigned to relevant committees, both to scrutinise on behalf of the board the plans as they're being developed for 25-6, and also to call in during the year to assure the board on in-year delivery. So a bit more to do in bringing that together, but I hope the board will see this is a further step forward for us in ensuring there's clarity and accountability across the ICB and what it's seeking to do. I am formally seeking today one amendment to the plan, and that was following the discussion at the last board meeting in relation to corporate parenting, I think at the time, and that if it's accepted by the board today will be the responsibility of our CNO to take forward this year, and again I would hope that we will then see further progress next year. Very happy to take any questions, as are the entire team, in relation to their respective portfolios.
Thank you, Steve. Any questions for Steve on the annual plan progress report? Kirsty.
Can I just provide an update on the CFO one around procurement? So that is now fully in place, and the procurement process has started in terms of the strategic scheme. So there's been a procurement to procure the company to help us, which is Capita. It's a system-wide process, and it's also part of looking at a target operating model for procurement as well. So that is in place, so we'll make sure that that's updated for next time.
Thanks, Kirsty. And Graham.
Thank you. So both in this report and in some of the others we've already seen today, I welcome the sort of move that we've made to better granularity about an area, and it's not binary about assured or non-assured. So I think that's a great thing to have. But I'd just like to reflect on one of the issues that does throw up, which is that there's a highlight per directorate, and I'm just trying to work out what the relationship between that is and the contents. So I won't necessarily pick on any one, but there's 2 or 3 other directorates where there are significant areas that are red, and yet it's fully assured. And I just think we have to be slightly careful about what do we mean by fully assured when there's elements that clearly aren't. So it's an observation more than a question, I think.
I might ask our assurance language expert, Sam, to come in on that.
Yes, I think we discussed this at Finance and Performance Committee, and I think this is a work in progress. And we used a judge of if we were 50% fully assured per directorate in terms of the total number of priorities, then we would take that as fully assured. We don't think that's right. We know that we will change that moving forward. We expect to see a significant move between this version of the report and the next version of the report in terms of the gap between fully assured, partially limited anyway. And I think as I said, it's a work in progress, and we know we've got to probably got to change that as we move forward.
Thanks, Sam. I think Tandy wanted to come in on this point, and Judy as well. So Tandy first. Tandy, your microphone. Thanks.
I just wanted to compliment exactly what you said is what also came up in the QPIC. So I think the system is working. We picked up exactly what you just picked up. So.
Thanks, Tandy. And Judy.
Again, this is great progress and just good to have the whole picture. I noted that there's one or two areas where we have an unknown assurance, and that's partly because there simply isn't the capacity in the organisation at the moment to do that. I'm hoping that as we make appointments and settle the structure with phase 2, that we will be in a position for all of these that we have set as objectives for the year to have some staff attention. And just next time we get a report, can we have a statement on that issue? Thanks.
Yeah, happy to pick that up, Judy. Thank you.
All right. Sam, did you want to come in?
Yeah, I think so. In terms of some of the unknowns, there are various reasons. So some of them might be that we haven't started them yet, and they're not due to come in until later in the year. Some of them would be that we may have put the resource in, but we don't have the ability to track the metric at the moment to understand whether we're making the move or not. So, and coming back to my previous point, the one bit that I did miss is that it will look slightly out of kilter because some directorates have significantly more priorities than others in terms of the number. And that is based on the resource within the directorates, etc. But also there might be more in number, but some of them might not be as complex as others. So I think we need to draw that bit out. One of the pieces of work that we are doing alongside this at the moment is a full BI review to make sure that we have the measures attached to the priorities, and as moving away from the IQPR and bringing that into the annual report will be clearly stating have we done the action? Have we seen the move in the measure? Some of them won't have measures because there'll be a yes/no type of statement, as in we will develop a plan, a piece of literature, so we will be monitoring that in terms of that development. But this will evolve over the next couple of months, particularly around the level of data that will be attached to give you the level of assurance of we've done the action, we've seen the metric move, or we haven't, and therefore what do we know about it? So yeah, lots of work still to do on this.
Yeah, thanks, Sam and Donna.
Yeah, I'd like to understand in terms of the metrics, is that because we're an outlier compared to other systems? Is it because we don't have the IT infrastructure in place? Is it a training issue? Is that a partnership communication issue? I think not for today, but I think we need to understand, because we want one version of the truth. But we also need the capability system to make sure we've got the right data. And I think across such a complex system, there are so many issues that can result in us not having the data. So understanding the journey of improvement and the data is going to be really important for us, but also the prioritisation of what data we really think is important to collect first. So I think understanding the issues underneath this is really, really important. Because other than that, we might have expectations that are just not reality in terms of starting from the foundations and then building that over time. And then finally, the other question is, there's always someone, someplace further ahead than us. So can we basically, in something like this, cut corners and get there quicker? So it would be helpful to understand all those questions, perhaps in a separate report, because I think it's integral to performance.
Steve, do you want to go back on that?
That might come in and then last sounds good. Yeah, I think that's really helpful. I think on your final point, having our heads up and seeing where people have solved issues, the sort of looking out piece, is something that maybe we haven't done a lot of in the past. That's based on my perceptions, I may be wrong, having not been here for very long, but I'm very keen to ensure as we look at the JFP for next year and also how we refresh it, that we're looking at best-in-class examples about how we can solve some really knotty issues, because there is always someone out there globally, sometimes it's just down the road, who've solved the issue that you need. So it's something about, when the board, part of the board recovery plan, about our capacity and capability is bringing in that thought leadership, and we've got some starting on that, but I think there's much more to do. I think on the data issue, I think Sam might correct me if I'm wrong, but my perception is probably not. There may be some lack of availability of data. It's more about, I don't think we've had complete clarity about what the metrics are that what would a success look like in relation to these, which is something we need to build on for next year. So we are clear that the board can see we said it was going to do this and did it, and that's probably more a question of clarity of intent rather than lack of data. Sam?
Yeah, I'd agree with it. I think this is about us maturing as an organisation, and a lot of this at the moment is a conversation within our own review process around if you did what you said you would do, how would you measure the impact and what does good look like? So I think what we're finding is that it's quite a complex BI and data scenario that we work in, with the number of providers and the complexities of getting that information in. In some areas, it's highlighting that we don't normally review and evaluate the impact. So our BI teams are then working across the system and externally to find out how do other systems measure themselves in those areas. In some areas, it's around the fact that we've never had the sophisticated view of breaking down what the numbers actually mean. I think coming back to the last point, though, what we are already doing now is moving into 25-26 planning. So within the next month, we're expecting each of our directorates to undertake a review of where do they already think they'll land at the end of this year. What, therefore, are their priorities for next year in terms of what's in the joint forward plan, the leftover from this year, the performance issues that we see across our system, and not just thinking around when the operational guidance comes out and it says, here's the bare minimum, what does good look like for Devon? So being really clear right at the beginning of this process that the national minimum might not be what makes the improvement in Devon. What does that look like? And therefore really thinking about next year's plan already whilst we're still working on this year's.
Thank you, Sam. Okay, so if there are no further questions on that, can we note the assurance report summary and the assurance levels for each directorate? And is the board happy to approve the proposed amendment of the annual plan, which is that the ICB will address significantly poorer outcomes for care experienced children and young people by tackling access and equity issues in care delivery, which is an amendment which would form part of the CNO as part of the plan. Are we happy to approve that? Okay, thank you very much. We're on to item 4.5 and the winter plan process and principles. So, Anthony, could I invite you to talk to this paper, please?
Certainly. Thank you very much, Chair. So the paper you've got in front of you outlines the approach. We're very much into development of the winter plan, and actually we started that piece of work in April with the evaluation of what had happened in the previous year. And this year our approach is recognising that winter isn't a surprise and should be part of our annual plans anyway, actually to look at what we can do to further mitigate the pressures from winter. And just bearing in mind that those pressures there is no direct correlation between attendance and performance, but actually there is a very strong correlation between length of stay and performance, however you define performance. We've convened a working group to work through a number of elements in terms of the review, the design principles, but also working on the basis that we are not expecting huge amounts of additional funding this year. And also, we're in a very different place in terms of performance. Last year, obviously, significant ambulance delays, constant requests for diverts across the system, which obviously has significant issues in terms of quality of care. But we're in a very different place now. So this is very much about building on what's working, actually what else can we do, and then looking at how we coordinate services across the system as well. That work is currently in its last couple of weeks before the first draft is produced. That will give us clarity on roles and responsibilities, escalation, and also how we will be coordinating functions across the winter period. We work on the basis that there isn't going to be any additional funding this year. However, just in case, we have been working with primary care colleagues to look at what potential we could do in terms of admission avoidance and attendance avoidance as well. And as we've discussed earlier in the meeting, we do have 6 current streams of work, all of which we're going through some impact analysis and modelling to see what we could do further with those to take us into a much better place across winter. So, as I said, we've got 2 weeks left of this work. The group will continue across the winter period, and we've had good representation from all providers, from the collaboratives, and also from the individual locality urgent care boards in feeding into that. So I think we've got a good group that we will continue to meet across winter to make sure that we're monitoring where appropriate, and also if we need to course correct, that we've got the mechanism already established to do that. We're working very much with the regional team in terms of their impact change analysis, but also the work they were doing with ambulance providers to standardise the offer across the southwest, responding to the point that Graham made earlier in terms of how difficult it is for ambulance services to navigate the different pathways, to actually put some standardisation across the southwest. And that's a piece of work that's been running over the last 6 weeks and is just coming to the end at the moment. And I guess the last thing really is to make sure that we're very clear about expectations across winter as well. Previously we had a winter director. We're actually not having that this year, and the reason for that is we're, I think, all very comfortable with our current plans, but also we need to make sure this is part and parcel of business as usual for the organisations, and that's very much our approach this year. Happy to take any questions, and more importantly, perhaps to bring the plan back here once it's finished.
Yeah, thanks, Anthony. We really welcome the opportunity to have an understanding of the process and principles behind the winter planning in advance of the plan being set. So thank you for bringing it to the board. I'll open it up for questions now. I've got Liz, Frank, Lincoln and Judy and Graham. Start with Liz, please.
Thank you very much, and thank you, Anthony. I would commend the kind of principles and processes that have been put in place, but may want to make a couple of suggestions before I do that. I think, when we think of winter, as setting providers, I think there's this kind of bit of a misnomer that winter is just something we start planning for in the autumn each year because we are required to deliver a plan. This has to be part of business as usual. And in line with what Sam said earlier, this has been very much part of our thinking on the operating plan from the outset. Yes, we will refresh our demand and capacity modelling to make sure that it's aligned to what we now know compared with our assumptions, and I can confirm that action is going ahead. The plans we put in place are the plans we're putting in place to manage effective urgent and emergency delivery in line with what we described earlier, and it's just making sure that we're testing those assumptions in terms of the impact of each of those and the timeliness of those against the expected trajectories. And we would expect then to test it. And I think if I was going to make a suggestion, I would wonder whether we need to just be that peer-to-peer review around those plans. We used to have these big events years ago, which I'm not sure they add huge value, but that critical peer-to-peer review of the plans, given what we now know, I think may add value. And the second suggestion would be, given the earlier conversation that Alex raised in relation to primary care and collective action, whether we just need to make sure that in our demand and capacity modelling, we've taken account of the potential scenarios of escalation of action in that area so that we can be assured that the capacity aligns to each of those scenarios. Thank you.
Thank you, Liz. Does anybody want to come back on that, Anthony?
I can respond to both those. I think that last year we did have a sort of winter preparedness event. We will be looking to replicate that this year because it was really good in terms of that challenge element, but also actually thinking about what else, and not just about winter, but actually informing plans for urgent emergency care going forward. So useful events, something going to be happening regionally, but we would want to be having something at a system level in sort of October, November time, and the team are currently looking at that. So absolutely.
Thanks, Anthony. So I think next, I apologise if I get the order of requests to speak out of order here, but I think Lincoln was the next person. Lincoln, thanks.
So thanks. I'm really gratified to hear it's now a business as usual year-round process. And I wonder if there is a process around how we get the data from the winter to inform some of our prevention activities. So, no surprise, there will be those that are linked to warm homes, for example. There will be those that are linked to vaccination. So although you have a global vaccination uptake, which is good, we would be interested in the granularity. So I think that idea of what's coming through your EDs, what's coming through, feeding into then a really good partner planning year round so that, we can at least make things better.
Thanks, Lincoln. How would we pick that up? How would we systematically pick up the point that Lincoln's making there?
As part of our analysis in terms of impact, we started doing some of that work already. Our business intelligence team are very good at modelling both what's happened from previous experience within this country, but also what's happening in other areas. And if you look on the basis of what's happened in Australia might have an impact on us at some stage, they're very much using that as part of our modelling in terms of scenarios. I think the heating bit is really interesting. I'm not quite sure how we'd capture some of that, but certainly we're looking at other factors that are coming as part of other changes that we would need to factor in that.
Just to follow up on the heating one, so within local government, there are certain schemes that we have linked in with the voluntary sector as well. So being able to triangulate some of that, we could help prioritise the kind of access. We have the disabilities facilities grants and other kinds of stuff that we have through adult social care that if we ask the question, then potentially we can unlock some of the resources.
We'll pick that.
Thanks, Lincoln, and thanks, Anthony. So up to Frank next, please.
Thank you. I was going to ask a question about how many of the GPs were involved in the planning, because it talks about community, but didn't say primary care. I'm delighted Anthony has clarified that. I think it's quite important for us to make sure that voice is strong enough. I haven't read the whole Darcy report, but in 2006, the percentage of money spent in hospitals was 47%. It is now 58%. One of the three drivers of the UEC problem is the lack of alternatives out in the community. And Darcy, I will quote, said, we need to lock in the shift of care closer to home by hardwiring financial flows. So there isn't any more money, but, things like, I know they're run by the hospitals largely, but acute hospital at home, all the UCR response times, all those things are the things that allow people to stay in the community. So having the community voice and perspective is really, really important in the development.
Thank you, Frank. Did you want to come back on that point? Okay. Anyone want to come back on Frank's point, Anthony?
No, I was just going to say that we've tried to hardwire that into the approach from the get-go. We're very conscious of the way things are moving, but actually trying to look at what's happened previously. I think the funding streams that we've inherited or how money has been allocated previously haven't made that an easy process. But certainly going forward, and part of the reason of working with PCNs was to look at if any of money did become available, actually how could we be spending it in local communities in a different way. And although we don't have the funding streams identified, we do have a number of those schemes already worked up. We've also committed to work with PCNs in terms of the quality of those submissions, because I think perhaps in the past there's been an issue with perhaps not being as articulated in terms of the impact that we would want. So we've certainly taken that piece of work on board to try and make those in a better state. Should monies become available, and I think you say should, then we've got something that's already on the shelf ready to go.
Thanks, Anthony. One of the things you've referenced the Lord Darcy report there, Frank. One of the things I am keen to do is outside of the board meeting that we look at that and pull out some criteria for success of the 25-26 plan in terms of our adherence to the principles of that. But that's some work to be done outside of the meeting, I think. But thanks for raising it. So, Judy, I think you put your hand down. I've got Graham, and then I've got Donna.
Thank you. So it always seems to me the challenge here is about you inevitably have organisational boundaries. yet for this to work efficiently and effectively from a patient and provider's perspective, it's around what happens within each organisation and the linkages between those organisations. So I very much welcome the planning, the focus now on the planning up front. I note that there's going to be a system coordination. So I'm really interested about who's been party to that, and are you satisfied that the parties are all round the table, as it were? And we've talked about primary care, we've talked about population health in it. I've already raised the question about the ambulance service. PPG and 111 isn't cited. I was slightly surprised at the NHS England's list of well, they say 10 impacts, but there's 9 listed. And I don't know what that means for us, but it's very much about what happens inside a medical setting. So are you satisfied that you've had the right people around the table for the planning and will have the right people, as it were, operationalising it? And particularly, I guess, 111 and where that sits into it and how they work with the 9s. Thank you.
In a short answer, yes. So far in terms of the planning elements, but I think that the test of this isn't just about the planning, it's about the delivery. And I think that's where we need to strengthen, certainly, our involvement from ambulance services, absolutely. Recognising some of their concerns has been a key element of what we're doing. So we've talked about the work that we're doing in terms of standardisation with the Ambulance Trust. That was kicked off to try and make winter easier for them. And I think that's been a good piece of work, both in terms of improving engagement, but also to make processes clinically much easier for frontline services. So I'm very satisfied at the moment. I think the test for us will be around delivery and making sure we maintain that engagement. The locality urgent care boards have been a key element within this, both in terms of primary care involvement, but also local authority as well. And we need to make sure that is maintained, particularly through testing times when we get into January. And so that's the focus of the team in terms of the report, is what that looks like without making it particularly onerous. We also put in something last year, and some of you may already seen the screen. When the waterfall on the wall subsides, it will be back up. But actually, we put in Shrewd last year, which is a very good electronic system which monitors system pressures. It also has a predictive element within it as well. So not only does it take data from the past, but it's able to actually predict what things will be looking like in the future. We put this in mainly to reduce the need for constant escalation calls, but also to make sure we were doing some predictions of what the weekend would look like, but what next week would look like, what the next few weeks would look like. We're going to continue with working with that and actually making sure that we've got a few elements where it's not quite feeding in as we would want it to be. Our local authorities have been engaged in that piece of work, and we would want that up and running before winter as well. The mental health element is also important, but that takes feeds from all of our acute providers and from SWAST and from PPG, and we discuss that on a daily basis with them. So that's another element that we feed into all of this. And I'm sure that we could arrange a tour of our system control centre for those people that haven't spent any time in it, because I think you'd find it very interesting.
Thanks, Anthony. I'm going to bring the last question in from Donna, then I'll ask Steve to come in after that. Over to you, Donna.
Yeah, in light of the recent changes of government, 180,579 pensioners in the Devon County Council area will not receive the fuel payment this winter. 9 in 10 pensioners in Devon will be affected. And even those who have the ability to take the uptake of the payment, only 63% nationally take up that uptake for a range of reasons. So, and there's going to be a 10% energy cap increase. And local government research recently, the discussion is about the fact that there'll be a fear for all those residents not to put on their heating this winter. We all know in this room what the consequences are going to be for the system in terms of falls and so on. So I think in terms of that preparedness plan, and in light of the decision made by government last week, there is a need for us to think about how we work together in public health and across the board in communicating to those affected residents in some way to encourage them to put on their heating, because what we've found is that it's that fear that they're going to get a huge bill that they can't afford that is the issue, rather than what is affordable. So I do think we've got in terms of prevention strategy, prior to the winter, there is something that we need to do collectively in this area, because that's a significant change, and it will have an impact on all that planning. I mean, when, you know, if you ask a director of adult social care at the moment, what do you think the impact will be? Well, it's more the question, what can we do between now and even November to try and address this issue collectively? So I would ask that I'm quite happy to look at how we might coordinate something with our communications colleagues, but I think particularly in terms of how our GPs can help us, what communication we can get out there. We've got something we need to do urgently in the next few months. So I would just maybe ask the board consider how best we do that, or make a note on this matter, because I am concerned it might affect all the plans we have in place.
Thanks, Anna. I'll ask Steve to respond to that in a moment, but I just want to bring Tandy in as well. Sorry, I missed you, Tandy, earlier.
The 2 points I wanted to make have just been made by Lincoln on prevention, as well as what you just said at the beginning, so I'll just be a bit pedantic now. You've listed 9 initiatives on there, but the line above it says 10. Have you missed out 1?
Yes, and you're going to ask me which one it is, aren't you? So it relates to minor injuries units and walk-in centres and UTCs. So that's the element that's missing at the moment, and it's specifically around the utilisation of them. We know that actually in Devon that is sometimes an issue. Firstly, in terms of availability, but also location, and also the categorisation, i.e., do we understand the difference? So a piece of work has been kicked off to look at that. In the short term, actually getting people up to specification, so the opening times are consistent, but also then to make sure that we're looking at the opportunities going forward. We have 11 different providers across the system at the moment, and actually that leads to some differences in service and also some inequitability. So we're looking at that as a longer term procurement piece as well.
Thanks, Santi. So I'm going to bring in Penny and then Steve.
Yeah, I really welcome the discussion that we've just had from, you know, the link with the public health perspective. And, you know, Lincoln, you will recognise from the data that actually increase in temperature can lead to increased admission. But what we are likely, there's some excellent work done 2018 and before and subsequently, but particularly the Nuffield Trust pointed to the fact that decreases in temperature lead to increases of people with respiratory condition, as we know, hence the RSV vaccination. But we have pieces of work ongoing with, I just wanted to make that link with the work we're doing around respiratory and the sophistication that we need around our winter planning. That is there, I think.
The drop in temperature, there's predictable within days, you get the respiratory first, but then you get the cardiovascular events, and as you spoke about the falls. So there's a lot of this which is known. And in addition to the global understanding what happens after a cold snap, similarly in summer you have the heat waves and how you plan forward for that.
Yeah, so a couple of things. I think the point around a comprehensive joined-up communication plan feels quite important, and probably something, Anthony, that we need to take away, get some people together across Directors of Public Health, local authorities, really to get messages out to the public about a whole range of things. Some of it will be around access to vaccinations, RSV, flu, those sorts of things. Keeping warm, and I think some messaging that we can agree with our local authority colleagues around that would be really helpful given the particular circumstances going into this winter, as Don has mentioned. And also it was in Wales it was called Choose Well, but essentially guidance to the public about where to go for what, and that would include, Anthony, the MIU point that you picked up. I think what I'm not seeing here at the moment is a comprehensive communication plan. It might be we've got the elements of that, but we need something ready to go before this board gets together again for its next public meeting. So if I could ask you to pull that together, that'd be helpful. One general point that I want to make, as we've gone through the discussions with providers, is that all of this plan is also predicated on an expectation that providers keep going with their elective care. So it becomes doubly important that we have plans in place that ensure we protect the elective pathways, not least because of the long waiting times and also the impact that will have on our ability to exit NOF4. And I just wonder, Anthony, to draw together the various threads of this, it would feel to me really important for the next public board meeting if we could have a sort of comprehensive winter plan for the system. Every provider's got it's expressed, I think, in bed equivalent deficit numbers, what they think the gap is, and a set of plans that address that gap. It may not be physical beds, but things that will either reduce the need for them or establish beds. We've got a set of plans that you and the new Director of Transformation have put in place around the out-of-hospital areas that will add a contribution to that gap. But I think the board being able to see that going into winter, this is our plan, at least expressed in bed days, would be important. And then as a second element to that paper, to pick up what you've described here, is then all of the processes and coordination and in the moment management arrangements that we're putting in place to ensure that as things happen, we've got system coordination going on. So I think perhaps a wraparound paper for the next meeting, it can include the comms piece, but I think we need to get on with that before the next meeting to get something on the ground ready to go. And then the board can be assured or to seek its assurance from the fact we've got a comprehensive set of plans then and a set of arrangements that will support us going through the winter.
Right, thanks, Anthony. So at that point, we've got an action there for the next public board meeting to bring to the board a comprehensive winter plan, which would include the communications plan. Thanks for the contributions to that item. I think that was really, really helpful. We have an action to take assurance from the approach that the One Devon integrated care system is taking to winter planning. Are we happy to support that recommendation? Thank you very much, and thank you, Anthony, for all your work on this. We're now on to the board assurance framework, and I'll just invite Helen to take us into that item. Thanks, Helen.
Thank you, Chair. The report you've got in front of you today provides the current position in relation to the board assurance framework risks. Following your endorsement of the 24-25 annual plan priorities at your last meeting, work's been taking place for this third iteration of the BAF to ensure that all of those actions and priorities have been incorporated. One of the downsides of this is it's now created a significantly larger document that you've got in front of you, but before you see the next iteration, work will be done to link the mitigating actions to control and assurance gaps and also group those actions together into themes to reduce that level of information. But what we wanted to do today was to just show you the amount of work and the amount of mitigating actions that are taking place around those risks. I'm pleased to report that there's now a much more integrated approach around the BAF that links into the annual plan and NOF4, which is resulting in the executives, the programme management office and the governance team working more closely together. So it should be a much more linked up approach going forward. Finally, I'd refer the board to a request that was made at your July meeting as to whether the residual risk score relating to finance and use of resources, BAF risk, remained appropriate, whether there should be a review of the impact element of the score. So last week at the Finance and Performance Committee, that request was considered and the committee agreed that no change was needed in the residual risk score at the present time, but that it will keep this under review going forward. So unless anyone has any questions, that's everything I'd like to say on that report. Thank you.
Thanks, Helen. And just to add to that, this report it does reflect all of the scrutiny of the board assurance framework that's taken place in the board subcommittees over the last couple of months. So thanks for that, Helen. Any questions for Helen? Okay, in that case, we will, if the board is happy, the recommendation is that we agree this third iteration of the 24-25 board assurance framework. Are we happy to agree that recommendation? So we move now into committee chair reports. We're running a little bit behind time, so what I'd ask committee chairs to do is to take the reports as read, but to highlight the escalation points to the board. And we start with the quality of patient experience committee report, and I'd like to invite Tandy to present that to us.
Yes, take the report as read, just escalating two things. One was the discussion we had on section 117 discussion, which is around the legal requirements that we are supposed to give to patients who have been hospitalised under certain sections of the Mental Health Act. We were assured that the policies and practices there are right, but there was an identification of a certain group of historical cases for which there was no recorded activity. So what the committee did there was to ask that that piece of work is looked at in more detail and to come back to the committee, so we are assured that actually there isn't any risks around that, and if there is obviously consideration to put that in the risk register will be done at that point. So that piece of work will happen and will come back to the committee. The second point for your attention was the patient and public engagement item, and for that particular one we were assured with all the activity that's going on around patient and public engagement, but there was also a request or recommendation to the committee that the patient and public engagement part of it be moved to the health inequalities committee, and so we're asking the board to approve that part. The patient experience part and quality will still remain with the QPEC.
Thank you, Tandy. Any questions for Tandy? If not, then let's note the report from the Quality and Patient Experience Committee and note the escalations to the board. Item 5. Oh, I'm sorry, Tandy.
To approve the proposal to transfer responsibility for the patient engagement to the health.
That's, we'll approve that as well. Sorry, tell me that again, Tandy. To change, could you put the microphone on to change the responsibilities for?
So we wanted the board to approve the proposal to transfer the responsibility for oversight of patient and public engagement from the QPEC to the Committee on Population Health and Improvement Committee.
Thank you. Can we capture that? Thanks. Yes. Thanks. Item 5.2 is the Finance and Performance Committee reports from the meetings of the 11th of July, 8th of August and 12th of September. There are two escalations in those reports, both of which I think have been covered in the meeting today. So the first one was around levels of assurance taken around the NOF4 exit criteria. I think we've probably covered that in detail in the meeting today. And on the 8th of August, escalating to the board the limited assurance that we'd received regarding the achievement of agreed in-year positions for urgent and emergency care, elective care and finance. And again, I think we covered that in the NOF4 report earlier. So if the board is happy with that, happy to answer any questions, but if not, we'll note the reports from the Finance and Performance Committee. Okay, thank you. And we're on to items 5.3, which is the Primary Care Commissioning Transition Committee, two reports from the 18th of July and the 15th of August. Judy, could I invite you to talk to these reports, please?
Yes, there's one item on the first of these, which was escalated to the board for action. So if I could just explain it, it's on page 489 of the 500 pages we have. The Primary Care Committee was unhappy about 500,000 of primary care money being put into the cost improvement plan. And the reason for this is as follows. We are locally underfunded on our primary care. We got some money this year, which has been used for a bunch of developments, but relative to national figures. Funding for general practice has been cut over the years. Frank's talk about the increase in expenditure on hospitals in recent years. Primary care is roughly 6% of the NHS budget at the moment. It was 8.9% in 15-16. So it is already being squeezed by the way in which the national allocation formula works. If you compare, our GPs, I'm using rough figures, get £100 a year for a patient, whereas an NHS bed day can cost anything from 350 to 1,600. So It's good value for money to keep our patients treated in primary care, not in secondary care. The current collective action is based on the fact that the last government offered GPs less than 2% in inflation increase on the contract this year, and it's been like that for the last few years, and yet GPs have to pay the same salary increases as the rest of the NHS if they want to employ good staff who can easily go and then work in a hospital if they don't keep up with it. The funds that are available are for contingencies and also for small minor developments that help practices improve their service to patients. And indeed, the regional assessment letter stresses the need for us to keep focusing on the whole system, and indeed, as the Darcy report does. I know we don't have time to talk about it now, but the Primary Care Committee asked me to raise this, and I'd be grateful if Steve and the executive could take it away and review that situation.
Thank you, Judy. I'll just ask Steve to come in to respond to those helpful points.
Yeah, thank you, Julie. I think we'd all absolutely agree with what the committee's reflection back is and the importance on this, and we've talked about it many times today around the need for the system to be balanced and to focus on primary and community care and population health as much as the other parts of the system. I think probably whilst we are where we are in terms of this year's plan, and that's been through many discussions, I think the commitment is to ensure, as we are developing the 25-26 plan, that we properly debate how we are shifting our resources and find those levers that will help us to at least start to move in the right direction around where investment goes. That's not to underplay just how tough it will be in a world where we are in deficit, and it's very difficult to double run, essentially, which is probably what's required. But I think the focus of the board going forward needs to be very much on those wider issues to ensure, as you say, we are putting money in the places that will have the most benefit to our patients over time.
Thanks, Steve. Is there anything else you want to report from your committees, Judy? I mean, I note also there are 2 recommendations to the Quality and Patient Experience Committee in your report, so I just want to check that the Quality and Patient Experience Committee is picking those up. They are to consider the ICB's position on GPs being asked to work above the British Medical Association safe working limits. Is this right,
yes,
Judy?
Sorry. Yeah, it's not quite as simple as that. It's ended up very simple in the paperwork. I will liaise with Tandy separately.
Great.
The plan.
Okay. So is everyone happy to note the reports from the Primary Care Commissioning Transition Committee from the 18th of July and the 15th of August? Thank you. And the final subcommittee report is from the Audit and Risk Committee of the 2nd of September 2024, and I'll invite Graham as chair of the committee to report back from the committee.
Thank you. So nothing to escalate to the board. There is a paper there, but let me just highlight, if I may, for a couple of minutes. I do chair a meeting periodically with the audit chairs from various organisations, and we have now moved to conducting some system-wide internal audit pieces of work. We've been discussing for time. I know there's a pace of change here, and there's a sensitivity, of course, about respecting sovereign organisations and their own need for internal audit work. But there are 3 in the works, 1 underway, which is around SIPs. I think we all recognise the importance of SIPs, and therefore there's some work which is towards the end of completion, sampling some of the schemes to look at the adequacies of the planning and the detail. And I know we've discussed at the board today something about the importance that is. I've asked for at least an interim findings to come back in time for the NHSE face-to-face meeting on the 17th, so I can get that to you. And then one that's in terms of reference stage is around ambulance handovers, one that some others were very keen to look at. Interestingly, our auditors, ASW, audit all of Devon apart from the ambulance service, and yet clearly they need to participate in that, so we will watch that space. And the 3rd is around maternity standards and its return. So pleased to report that I think so far so good in terms of system-wide audit work. A couple of things just to note in quick reference. policies, we checked that all the policies are up to date. There are some which will need updating. We'll watch that space. We put in place a new policy around petitions and when they should go to board. We said we would just watch out to see how many didn't make the threshold. We will review the need to continue to get a report on that in due course. There have been none received so far. Internal audit is on plan, which is better than last year. We've had a flurry of reports at year end and would rather not do that. External report. We haven't yet reviewed, but there is now available the Mental Health Investment Standard. We will be looking at in January. And then the last thing I'd highlight is the FTSE, the Freedom to Speak Up. I think we're very keen to make sure that the ICB as an organisation has got an appropriate culture, and the freedom to speak up is an element that feeds into that. So we did spend quite a lot of time thinking about that, and we will be looking a bit more widely in due course. So that'll be me done. Open it for any questions.
Thanks, Graham. If there are no questions, then let's note the report from the Audit and Risk Committee. We now have some closing items. The action register. So I'm not going to go through this line by line, but I think what we're asked to do here is to agree the closure of actions 59, 61, 62 and ICB 24, 8A, 12, 29, 32, 33, 36, 37 and 40. Is everybody happy with the recommendation to close those actions? And are we happy to note the updates in respect of actions 68, 69, 71 and ICB 24, 9, 37C, 38? Okay, we discussed earlier in the meeting the action relating to ICB 24037B, and we've agreed that we will take that outside of the meeting and provide an update at a future meeting. Is everybody happy with the update on the action register? Next item, can I just check again? We've got no questions from members of the public, Helen. Okay, so we can move on to any other business. Is there any other business from anyone in the room? Alex, please.
Thanks, Chair. Sorry, just there was a question earlier about ADHD medications, and I've just got an answer from the MedZop team. Excuse me. So it seems there has been an improvement in the availability of medicines for ADHD, although for some of the medications they're a little bit sporadic. We've heard that there may be a resolution by the end of October, but we're not 100% sure on that.
Thanks, Alex. That's really helpful. So if there's no other business, let's just note that the date of the next board meeting in public will be the 28th of November 2024. And can I thank everybody for the really high quality papers today and for the really good contributions that we've had to the meeting. Thanks very much, and I'll see you next time. So while we've still got Judy on the line, shall we take 15 minutes break? Come back at 1 p.m.